public session. Is that agreed? The purpose of this morning's meeting is to examine in detail the reasons for the huge projected cost overruns at the new Children's Hospital and to welcome the National Paediatric Hospital Development Board to give evidence in relation to this issue. So on behalf of the committee, I would like to welcome Mr. Tom Costello, Chair of the National Paediatric Hospital Development Board, Mr. John Pollock, Project Director, Dr. Emma Curtis, Medical Director, and Ms. Ailish Hardiman, CEO of the Children's Hospital Ireland Group, to the meeting. Thank you. Just on housekeeping matters, I wish to draw to your attention the fact that by virtue of Section 17(2)(l) of the Defamation Act 2009, witnesses are protected by absolute privilege in respect to their evidence to this committee. However, if you are directed by the committee to cease giving evidence in relation to a particular matter and you continue to do so, you are entitled thereafter only to qualified privilege in respect of your evidence. You are directed that only evidence connected with the subject matter of these proceedings is to be given, and you are asked to respect the parliamentary practice to the effect that, where possible, you should not criticise or make charges against any persons or entity by name or in such a way as to make him or her identifiable. I also wish to advise you that any opening statements you have made to the committee may be published on the committee's website after the meeting. Members are reminded of the long-standing parliamentary practice to the effect that they should not comment on, criticise or make charges against a person outside of the Houses or an official either by name or in such a way as to make him or her identifiable. Can I now ask Mr. Costello to make his opening statement? Thank you.
Chairman, Chairman, members of the committee, thank you for inviting us here this morning. In August 2013, I was truly honoured when asked by the Minister for Health, James Riley, to chair the National Paediatric Hospital Development Board. That's the board with the remit to design, build and equip the new Children's Hospital for the island of Ireland. The proposed new Children's Hospital development is the most significant capital investment project ever undertaken in healthcare in Ireland, bringing together 3 children's hospitals in a modern, custom-designed building to deliver the best care and treatments for Ireland's sickest children. I was joined on the board by 11 other dedicated members with the collective skills and experience of major projects to deliver on the responsibility with which we were entrusted. That is, to build a world-class children's hospital on the site of St. James's campus. The urgent need for a new children's hospital for the country has been recognised for decades. Acknowledging the importance of the challenge ahead of us and the realisation that we were building a hospital that will care for sick children and their families for many generations to come, we set out a bold vision for the project. And if you don't mind, because the statement is a bit too long, Chairman, in some cases I have shortened it just so that I stick within time. So the vision for the project was to deliver one of the finest children's hospitals in the world, and specifically a hospital that provides a truly supportive and therapeutic environment for children and their families, a safe and stimulating environment for staff, recognising the importance of wellness, a hospital that's sensitive to and positively enhances its urban setting and the quality of life of the local population, a hospital with a layout, detailed design and construction quality that will facilitate the optimum delivery of all aspects of leading, current and developing clinical practice, indeed a leading-edge, fully digital hospital. A hospital that's cost-effective in terms of capital costs and whole-life costs, with sustainable solutions integrated into all stages of the project life cycle, and in that regard we have targeted BREEAM Excellent and BER A3 standards. Moving on then to design team selection. With a clear vision for the project and an experienced executive team in place, the board then put in place a structure and process for design team procurement, moving on to securing planning permission and thereafter procurement of contractors to ensure a timely delivery of the new hospital, while at the same time working closely with St. James Hospital in decanting the buildings from the 12-acre site which was identified for the new Children's Hospital. Following a comprehensive procurement process, we reached our first major milestone with the appointment of the design team in August 2014. Thereafter, the design for planning was produced in the most expeditious manner, Planning application was lodged in August 2015 and On Board Planola granted planning permission in April 2016. And this was a major hurdle crossed for the project following the experience on the Matter site previously. Decanting of the buildings from the 12-acre site identified for the Children's Hospital commenced immediately, and an enabling works contract which focused on demolition was commenced in July 2016. Moving on then importantly to the procurement model for contractors. Shortly after receipt of planning permission, the procurement process for contractors began in June 2016. Earlier, a procurement subgroup was established to define the most appropriate approach to contractor procurement. The group included our board, HSE Estates, and members of the Government Construction Contracts Committee. Given the history of cost overruns and adversarial behaviour on public sector projects, it was decided to consider alternatives to the traditional form of tendering. Reference was made to lessons learned and evolving best practice in UK and internationally. And the universal challenge in all was to replace adversarial cultures with collaborative ones. As an example, then, the construction of Terminal 5 at Heathrow Airport is held up as a prime example of collaborative working. Prior to construction, the British Airport Authority conducted a 2-year study in which every major UK construction project of over £1 billion completed in the previous 10 years was investigated. The two main areas identified by the BEA which contributed to the general poor performance across all projects were a lack of collaboration among project partners and the client's reluctance to assume responsibility for project risk. The procurement model for the NCH had to align with EU procurement rules and also work very closely with the established government construction contract forms. Following deliberations over several months, including presentation of the proposed option to the Government Construction Contracts Committee, the Strategy Group recommended a 2-stage tender process for procurement of contractors. This process was then, and remains, the accepted best practice internationally for procurement of large-scale, complex projects such as the Children's Hospital. Among the benefits of the 2-stage approach that have accrued are: it attracted the desired calibre and number of local and international contractors to bid competitively for the project. It enabled tendering to happen prior to the completion of the full detailed drawings for Phase B, meaning that the Phase A construction could start 2 years earlier than if a traditional procurement strategy was deployed, and allowing the bulk of costs to be secured at 2016 levels when they were tendered. It also facilitated early contractor involvement by the contractors in the design development process, with critical input on buildability, contractor and supply chain integration, risk management and innovation, resulting now in the completion of a fully integrated design. And then critically, prior to commitment of expenditure on the main building works, there is now certainty on the cost and programme, with client and contractor risk reduced or eliminated. The programme includes delivery of a fully commissioned and quality assured building. And the 2-stage tender process has and will continue to foster a collaborative culture, eliminating the traditional adversarial and opportunistic behaviour. Tenders were issued in 4 lots: main contractor, mechanical, electrical and lifts. Stage 1 of the 2-stage tender involved the works being bid on the basis of a preliminary design and an approximate itemised bill of quantities based on that design. The contractors provided rates for all elements of the works. Stage 2 then included the designers and the contractors working together to develop the design to completion. The tendered rates are then applied to the final bill of quantities produced by our quantity surveyor. The actual cost is determined by multiplying the final quantities by the tendered rates. In cases where there is disagreement between our QS, line site and the contractors, this is resolved by the independent expert whose decision is binding on both parties. First stage tenders were returned on the 21st of October 2016. The lowest bid of 637 million was received from BAM. It was very competitive. Indeed, it was 131 million lower than the second place bid. Following a detailed tender assessment, preferred bidders were identified in February 2017, and that was BAM as the main contractor, H.A. O'Neill Mechanical, Mercury Engineering Electrical and Schindler for the lifts. The final brief and definitive business case were approved by Government in April 2017, enabling the Board to commence Phase A of the build, namely the below groundworks, the basement excavation and construction, while the adjusted contract sum was being determined. The total capital cost identified in the project brief was 983 million. As the tenders returned were substantially above the quantity surveyor's pre-tender estimate, there was pressure for cost reductions. The capital cost of 983 million included a target amount of 66 million for cost reductions or value engineering. Additional costs of 61 million were reported, mainly relating to fire officer requirements, including sprinklers, and costs associated with programme alignment between the main contractor and the specialists. The contract was signed with BAM on the 3rd of August 2017, and work commenced on site on the 3rd of October. We recognise at this stage a major procurement exercise had been completed successfully, and a hugely significant milestone for the project. We had begun construction. Go into a bit more detail then on the second stage. At the same time as works commenced on site, the contractors began the engagement on the design development of Phase B with the design team. The two-stage procurement process transfers the risk to contractors in relation to costs, quantities, coordination issues, any project delays unless caused by client changes or lack of design information. As the design development progressed from October 2017, the design of the earlier packages, such as concrete frame, steel frame, stone cladding, internal walls, were completed and costed and were trending within expected costs. This trend changed by mid-2018 as the design for the very complex mechanical and electrical systems, in total there are 24 different systems between the mechanical and electrical, as they were completed, and it became clear that there was a very significant gap developing between the estimated quantities at tender stage and the quantities that were now required to deliver the completed design. With this very significant increase in project scope came also the requirement for an extended programme and the costs associated with the programme extension and the additional scope. Working closely with the project team and external advisors, we scrutinised all costs as they became clear, dealing first with the increase in the construction cost, which ultimately came to 320 million. The process of determining the costs of the various packages was fully interrogated and independent reviews were commissioned, validating the fitness for purpose of the mechanical and electrical design and reviewing the adherence to agreed procedures during Stage 2. The contract allows the Board, if it sees fit, not to proceed with Phase B building works with the main contractor, and therefore we explored the alternative options for project delivery, including, if it was the correct option, not to proceed. It became clear after this exercise that the option to award Phase B to BAM would result in the lowest cost and the fastest completion by a significant margin, and this is covered in slides 18 and 19 in the pack that we have issued to you. On completion of the various exercises, the Board were satisfied that despite the huge disappointment with the outcome, proper procedures were followed through the Stage 2 process in determining the final contract sum, and the correct option to complete the Children's Hospital was to proceed with Phase B. Following our meeting in November 2018, the Board made a recommendation to the HSE and the Department of Health that the works should proceed as set out in the agreed tender process, to instruct BAM to proceed with Phase B, the main building works. And I'll go through some of the detail on the cost now, but we can go into greater detail later on. And I'll just switch the two around in the sense that I'll deal first with the construction costs at a high level, where the sum of 570 million, which was included in the approval of the overall 983 million in early 2017, that increased by 320 million up to 890 million. And the main drivers there were, as I mentioned earlier on, we had targeted savings of 66 million. At the end of the day, we achieved 20 million. So that added on 46 million to the project. The statutory issues such as the fire regulations following the Grenfell fire and the sprinklers added 27 million to the project. And then engagement with clinicians on the final design added a further 21 million. So with those three elements, there was 94 million added to the figure of 570 million. And then, in essence, the result of the Stage 2 process were through design development, in relation to design development element, there was 94 million addition. There were omissions in the design at tender stage, which through the design development process were brought into the final design of 20 million. And then the impact of the 9 months extension of the programme and the additional scope added 90 million. And then, as happens in construction contracts, there were additional claims from the contractors to reflect the changes in scope. At the end of the day, through the intervention of the independent expert, they were settled and agreed at 22 million, which takes us up to the 890 million. And we can go into greater detail on that later. As well as the increase in construction costs of 320 million, there were additional costs of 130 million relating to VAT of 50 million, additional costs on the satellite centres at Tala and Donnelly, staff, site supervision, design team, medical equipment and risk and contingency. The final project cost is now 1.433 billion, 450 million higher than the figure of 983 million approved by the government in 2017. Following the government approvals to the investment decision, the Phase B works and the main building works have now been instructed to BAM, with construction works of the main hospital on the St James's campus to be completed in mid-2022. Go on then to coming close to the end of it, on benchmarking. In early 2014, the Paediatric Hospital Board prepared a preliminary budget, and it's detailed on slide 11, showing the project costs of 800 million. This was based on advice from ACOM, who were the quantity surveyors for the Mater Children's Hospital proposal. The estimate included construction cost per square metre of 2,500 square metre, which was the appropriate cost at the time, and we were at the time in a deep deflationary period. And we allowed an inflation allowance at the time, which again had been the trend of 3% up to 2019. So in the ACOM estimate, which brought us to a total of 800 million, there was an overall cost per square metre of €2,875. An international benchmarking report completed by ACOM in October 2018 concludes that the average construction cost per square metre for an international hospital project similar to NCH is now 5,951 square metres, more than twice the estimated cost of construction in 2016. And indeed, this is borne out by information in the industry in relation to on the period from a decade up to 2022, that construction costs for large complex projects in the Dublin area will have increased by up to 100%. The cost per square metre for the Children's Hospital is 6,500 square metre, so it is above the average, but not above the maximum cost, above the average of €5,951 per square metre. To conclude then, the timeline to deliver the new Children's Hospital from the appointment of the board in August 2013 to the project completion in mid-2022 is a total of 9 years. I'm satisfied that the board and the executive team have set about the task in a competent and professional manner, putting in place the most appropriate structures and processes based on best international practice. If we were to start again on a project of this scale and complexity, we would adopt the same procurement approach. Notwithstanding this, we are deeply disappointed and acknowledge the very significant increases and the challenges these pose. There are lessons to be learned in relation to the wisdom of pursuing cost reductions on competitive tenders and ensuring the sufficiency of tender information, in particular mechanical and electrical services at tender stage. This would have ensured a more accurate prediction of actual quantities and costs at the tender stage and to a large extent it would have reduced the underestimation of costs at stage 1. With cost and programme certainty now achieved, our focus is on ensuring that all parties work safely and collaboratively and deliver a hospital of outstanding quality, a project we'll all be proud of, one of the finest children's hospitals in the world, providing unsurpassed care for the nation's sick children for generations to come. At the same time, we're very mindful of the Government's concerns to ensure that the project is indeed delivered within the agreed time and within the revised budget. We welcome the planned independent review of the Board's processes and procedures. Any issues identified will be dealt with speedily and comprehensively in the interests of successful completion of the project and the effective management of public funds. Thank you for your attention. My colleagues and I, Chairman, will now be delighted to answer any questions you have.
Thank you very much, Mr. Costello. Could I ask you, Mr. Costello, could you explain to the committee why these overruns were not anticipated? Was it a fault in procurement or tendering or both? Because expressing deep disappointment, I don't think, reflects the frustration and the anger of this committee in what has happened, because we want to find out who is responsible for these failures, because this is an unprecedented overrun in one of the largest infrastructural developments in Ireland, and it now is going to have one of the largest overruns. And the consequence is not just confined to the National Children's Hospital, but these cost overruns are going to have knock-on effects in all capital investment in our health service over the next number of years, including the National Maternity Hospital, the National Forensic Hospital, the National Rehabilitation Hospital, the building of elective-only hospitals as identified by Sláintecare, the primary care programme, the replacement of equipment which is necessary in all our hospitals, and also the transitional funding that's going to be required to develop Sláintecare reform. So it's not just an overrun in the hospital, the Children's Hospital, it's going to be extremely damaging to all capital investment over the next number of years. So I'd just like you to answer why these overruns were not anticipated. The second question is, what have you identified as the premium for building the hospital at the St James's site rather than on a greenfield site? Because obviously there was a huge cost in, as you described, decanting buildings and demolition before construction was to take place. And thirdly, why has the cost exceeded the international average and become the most expensive children's hospital in the world? What are the factors that have led to that overrun? So perhaps then, why were they not anticipated? The knock-on effects that are going to affect our health service, the premium of building in St James's, and the fact that it is now one of the most expensive hospitals in the world.
In relation to your first question, we should be mindful of the fact that we're in a hugely inflationary time, from having come through the recession, the period from 2012, 2013, up to and the decade after that. As I mentioned earlier on, it's likely that building costs will have increased by up to 100%. We set out on a journey, and it was a deliberate approach in terms of how we structure the project. The two-stage tender process was internationally regarded as the best approach to do it, whereby you go out to the market with a preliminary design, but with every element of the project identified, but the quantities not finalised. We went through the process, and I went through earlier on what were the advantages of going this route, and these are advantages which have accrued now and will in the future, so that right now we have got to a stage where through that process we have now got a firm price. It's a price certainty in relation to the cost and programme certainty. I mentioned that there were two issues in terms of lessons learned around seeking to get cost reductions when you had a very competitive tender, and that in hindsight, probably, despite the fact that there was pressure on the budget, mainly driven by tender price inflation, there was pressure to reduce the cost and find cost reductions. And also that at the end of the day, people have to remember that it's a huge project. Like you mentioned about the project being one of the most expensive hospitals in the world. It's also one of the biggest children's hospitals in the world. And it's important to remember that. And because it's big, it's extraordinarily complex. And the part of it, while people might walk into a room and say a room is a room, the infrastructure behind that room to deliver a fully digital hospital is absolutely enormous. So at the early stage, the design, the complexity of those services wasn't fully recognised in terms of the quantities that were within the early stage tender. And as the design developed, that became clear, and I went through that stage of how that developed over 2018. And it's important to remember, though, at the end of the day, is that the quantities that are now applied to the rates we got in 2016 are the quantities that are required to deliver the project.
My question was, why were these not anticipated?
Well, in the sense that the complexity of the project, we anticipated that, for instance, of the 5,000 kilometres of cable in all different sizes, we have rates for each type of cable, but the actual quantum of it wasn't fully defined in the documentation. And that it's now fully defined. And when we learned of the huge increase, we got an outside review done to say, well, okay, have we over-designed the building? And at the end of that exercise, the feedback we got, no, the building is fit for purpose for a modern, fully digital hospital. So what we've done now is that the quantities that have to come out of that two-stage are applied to the rates we got at tender in 2016, and that gives us the final cost. Does that deal with that? Okay. I know in fairness it's complex, and because of the quantum, it's difficult to understand. But that is the nature of. We set out on the journey of doing a two-stage tender, which means that at the beginning, the rates by their nature are approximate.
In relation to the premium of building at the site in St James's, have you estimated what percentage of cost is that premium building at that site?
I don't have. I mean, I don't have the cost. There's a big premium of building on any site in Dublin. That is the reality.
This particular site had certain costs built into it in relation to demolition and decanting of buildings, as you described in your opening statement.
That information is available, and we can go back, but I don't have it to hand here. But in terms of
to the committee,
we can do that. Yeah, we'll follow up with that. Yeah. Yeah, John, do you want to go in? Yeah.
If I could, so maybe adding that in relation to the 320 million increase in costs that we're reporting here today, none of that is associated with being on the James's campus. So these are costs that would have occurred on whatever site we were on. So, for example, the statutory issues around sprinklers and around the Grenfell fire, they happened, and we obviously then had to comply with those changing regulations. Omissions in the bill of quantities, the scale and complexity of this job, I mean, it's 158,000 square metres, which is the size of Dundrum Shopping Centre. And within that 158,000 square metres, it's got a huge level of complexity with 6,000 rooms, and the level of services. And Tom has spoken about the digital hospital, and this is the first public digital hospital in Ireland, and that again comes with cost impacts. So, for example, people kind of say, well, what does a digital hospital mean? So it means that we no longer rely on paper records. Everything is now digitised. We've got electronic healthcare records. So clinicians will be using their iPads and tablets to connect with records. Every piece of equipment which needs an interface with the electronic healthcare records, so everything is stored centrally. And that has an enormous impact for the design of the building, so that in order to make sure there's resilience built into the hospital, because if the IT systems crashed the old days, you may have lost a piece of paper, but now the entire system would have gone down. So in all those 6,000 rooms, we would have multiple data points for pieces of equipment and for staff to connect into, but each one of those data points is replicated, so in case something goes down, so you have an A and a B. But now they all have to go to a separate computer room, because if they went to the same computer room, if that computer room failed, and then they also need a separate power supply each, and then they need a backup generator each. So there's a huge amount of resilience and duplication in a digital hospital.
Why would that not have been anticipated in the original design, procurement and tendering?
So when the user engagement piece that we set out day one in terms of getting on the site 2 years earlier than with a traditional procurement model, was that we engaged with the users, we took typical rooms, but we didn't design all 6,000 rooms at that stage, because that would have taken us a further 2 years. But we got prices for everything. So when our tenders came back in 2016, we had prices for all those pieces of equipment and IT points. But the quantities then increased through the detailed design development more than anticipated.
Thank you very much.
Find it clarity, though. So, I'm not asking a question.
Okay.
Are you saying effectively, because I listened to Tom as well, that so you got the price for the cables, but you didn't know how much of them you'd need?
That's it, and that's the nature of the two-stage, because the design was at a preliminary stage, Deputy, when we went to tender, and that meant that is the way two-stage tender works. You bring in the contractors for their expertise, rather than actually bringing in the contractors when the whole thing is designed, and then for the next 5 years, the contractors seek to dismantle, in essence, and create opportunities for themselves. So what we have done here now is the contractor has worked collaboratively with the design team to finalise the design. But yes, it's right to say is the absolute quantum of cables, if taken that as an example, wasn't known until the full design is done. And you know, when I mentioned earlier on, John, I think the figure of about 5,500 kilometres of cable. So that's the quantum we're talking.
We'll come back to that point. So just to alert you to the fact, we're going to take a break at 11:30 for 20 minutes or so, just to give people an opportunity to recharge their batteries. So
You had a final question there, Chairman, if you want me to just answer it. Why has the cost exceeded the average, right? So the average cost from the exercise that was done by ACOM is €5,951 per square metre, and in the Children's Hospital here it's 6,500. The highest cost of the hospitals was €8,000 a square metre. And just to answer specifically your question, why is it more expensive? Is Dublin is an expensive place to build at the moment, but mainly because we genuinely did set out, and when I talked earlier on about the vision, we set out to build one of the finest children's hospitals in the world. It's also one of the biggest children's hospitals in the world. And there are elements around it that do cost money. So in terms of providing a truly supportive and therapeutic environment for children and their families, is all of the 380 rooms are private rooms, ensuite, with space for the parents to sleep. That's that's a quantum shift from what we're doing now, right? Also, we've created gardens. There's a garden the length of Crow Park in the roof, the Rainbow Garden. And that's about the recognition, and Emma in due course could come in, that is the importance of all of this in terms of healing. And then we talk about the sustainability. So the building we're building, it does cost more to put in energy efficient systems. But over a period of time, in terms of life cycle, they yield huge savings. So we set out to build an outstanding hospital, and there is a premium. It's not too good. It's actually fit for purpose, but it does deliver on what we set out to do, to build one of the finest children's hospitals in the world.
suppose, before I bring in Deputy Donnelly, the premium, unfortunately, is now that every other capital project in the health service is going to be set back a number of years because all money is going to be directed to the Children's Hospital, including money from other departments, as far as we can gather, to try and pay for the hospital. So the premium is excessively high, in my opinion. But I'm going to bring in Deputy Donnelly now to introduce our other members. Deputy Donnelly.
Thank you, Chair. Thank you all for coming. Mr. Costello, I've looked at this in some detail, and when it comes to the costs, I believe you and the board have failed completely and catastrophically in your job and in your obligations to the state. When the dust has settled, the original bid from BAM came in at about 640 million. Now, when the dust has settled, I don't think we're going to see any change out of much less than 2 billion. So I think you will have overspent, when this is all done, by somewhere between 1 and 1.5 billion euro, and it could be higher. Now, the entire fiscal space for the entire country last year was less than €1 billion. If you think of the work and the analysis and the oversight involved in deploying that 800 million or so euro, you and your team were down in St. James's spending more than that. And as the Chair says, a cabinet memo from December begins to outline the costs of that. So hospital beds, additional hospital beds won't happen, new emergency, cancer and cardiac facilities, primary care facilities, long-term residential units, accommodation in the community for people with disabilities, new laboratories, new operating theatres, investment in paediatric blood services, the second cath lab in Waterford, new emergency department and cystic fibrosis facilities at Beaumont, no development of appraisals and early planning for Sláinte care capacity projects at least until 2022. So that's the reality of the incompetence and failure that I think we are seeing in terms of the financial control of this project from your board. Now, you keep talking about a figure of 890 million. The figure that the Taoiseach gave the Dáil was 1.433 billion, and the memo which Minister Harris presented to Cabinet said 1.73 billion. So can you tell us at this stage what the total cost, I'm not interested in phase 1, phase 2, above ground, below ground, kit out or commissioning. What is the total cost to the state by the time the doctors, the nurses and the children actually get to walk into this hospital? Is it the 890 million you keep talking about? Is it the 1.4 billion the Taoiseach talks about? Is it the 1.7 billion the Minister for Health talks about? Or is it indeed a higher figure than all of those?
I'll try and clarify that, and I respect the fact that with so many numbers it is confusing maybe and certainly complicated. The construction, the BAM, when we talk about the contract, that's a figure excluding VAT, and it's the construction of the Children's Hospital at St. James's Hospital. It doesn't include the satellite centres, it doesn't include design fees. So the tender, when we talk about the tender for BAM, is solely for the construction, the construction costs only, and not an overall development cost for the project, which includes not alone, as I said, the Children's Hospital James, but also the satellite centres and the associated costs of design fees and staff and all of that, right? So that 640 million through the stage 2 process has gone to 890 million. So that's just that's the increase there, and we're talking about two different quantums of work when we're talking about one and the other, and we're also talking about a shift of risk and getting to a place where there's certainty. And certainty on a large, complex project.
Just in the interest of time, the question I've asked you is how much money is this going to cost?
Yeah, I'll come to that, but I just want to clarify first of all that in terms of the 640 million and the 890 million, they're related. That's the construction price, right?
Right.
In relation to the overall development, the figure at the end of stage 2 is 1.433 billion. and we are certain at this stage that we have, through the design process and the contractors, because we've gone through when we talk about quantum now we know exactly the quantities. The contractors have bought in, and now they take the risk on the quantities, so down to the finest detail.
So do you recognise the 1.73 billion in the Cabinet memo?
Yeah, and if you don't, I do indeed. I recognise the figure. And the responsibility of our board is in relation to the design, build and equip of the hospital, and thereafter in terms of the operation of the hospital and the start-up of the hospital. That's Children's Hospital Ireland, which if Eilish, if you don't mind, you might just explain what the add-on...
Mr. Costello, would you please, could you answer, what I want to know is the final number. Could you give us that, please?
No, so in terms of the responsibility that my board has, our final number is 1.433 billion.
And the total final number to the state, what is your estimate of that?
If I could just ask Eilish then, because that is outside the remit of the Paediatric Hospital Development Board.
So the total build, you believe, will not exceed 1.433 billion euro?
Correct.
Okay.
Right.
And that is up from approximately 640 million, which was the initial bid?
No, it's not. The initial was the 983. So just
well, the initial bid was 637 million.
Yeah, but that has increased to 890.
I know it's increased. The initial bid was 637 million.
Yeah, that's just for the construction only.
Right, and the construction is 1.43 billion euro.
It's the total development in terms of the construction price. The BAM contract is now 890 million.
I know what it is, but they bid 637 million.
Correct.
What was not included in that is included in the 1.43 billion?
There's a whole, John, do you want to just go through in detail on that?
Yes. So BAM's bid was, as you say, 640 million, and that's purely construction. That doesn't include VAT. It doesn't include the 2 urgent care centres at Donnelly and Tala. It doesn't include the decant and creche at Tala. It doesn't include the enabling works, the decant at St James's Hospitals, Aspergillus. So there's a lot of other construction contracts which are part of the Children's Hospital. But the construction piece that BAM tendered in 2016 was 640 million, and that piece is now increased to 890. And on top of that then...
So if the Children's Hospital is going to cost about 900 million euro to build, what's the other 500 million euro being spent on that gets us to 1.4 billion?
I'm just coming to that, Deputy. So the other elements that are not included in that are the urgent care centre at Tala, the urgent care centre at Donnelly, which is going to be completed in April of this year.
Yeah, these are small. So these are 5,000 square feet. Even if you apply your massively inflated euro per square metre, you get to about 45 million euro. That leaves about 450 million euro.
I'm coming to it, Deputy. So it doesn't include, as I say, the decant works at James's to clear the 12-acre site. So that was 16 million euro.
Okay.
It doesn't include the equipping of the hospital, and that's obviously a massive contract in terms of the equipping of the hospital. That's about a 70 million euro contract. It doesn't include value-added tax, which all told for the entire project is about 200 million euro. Our own project costs, our staffing costs, our design team costs, legal teams, procurement, advice, all the other costs. We've taken out a project insurance policy on the entire project, so we insure the entire project to avoid splitting responsibility for the project.
Thank you. Can I ask, in the interest of time, can I ask, for the things that matter to the public and to the children, right? We've gone from about 640 million. We've added in some pretty small, low-cost satellites, and we've said we had to clear the site, more or less. And we've gone up to 1.4 billion euro. How many extra beds are we getting for that increase?
The scope and the brief of the hospital was set out day one, and as Thomas said, this is one of the largest.
No, I'm not asking you what size it is. I'm asking you how many extra beds we're getting for this massive additional spend.
The scope of the project was set out day one. It is 470 inpatient beds. That's the level of beds that are
I
required to
understand.
serve
The question I'm
capacity.
asking, if you could just answer directly, I'd really appreciate it. How many extra beds are we getting?
The hospital's about far more than just beds.
I'm not asking you what the hospital is about. I'm asking you how many extra beds we're getting. Is the figure 0, 10, 100, 200? What's the number?
The project has 470 beds.
How many extra beds are we getting for this overspend? Please just answer the question.
It has the same number of beds as we had.
Are we getting
There's
any? Are we getting any extra beds?
There's no extra beds.
No extra
in the
beds. Okay,
hospital.
thank you.
If I may, because that's probably more appropriate to be answered from the services perspective. We're getting extra beds from what we have at the moment, if that is your...
No, it's clearly not my question. My question is how many extra beds are we getting for the massive additional overspend that we're here to talk about this morning? Can I ask this? I don't accept your benchmarking. I've looked through it in some detail, and I think you've left out all sorts of costs. So I think you're benchmarking in terms of, well, it used to cost 2,500 per square metre, but gee, now it costs 5,500 per square metre 4 years later. I don't accept it. I don't accept it as a rationale. The only explanation you seem to have given here is that it somehow has become twice as expensive to build in Dublin, but the site cost hasn't gone up because the state owned the site. Bricks have not become twice as expensive in 3 years. Labouring fees, wages have not gone up 300% in the last 4 years. I don't accept that. What we do know is that when this is finished, the cost per bed will be, to the Irish state, will be about twice the cost of the most expensive hospital ever built anywhere in the world. How is it conceivable that you are managing a project that the Irish people now are going to have to pay twice as much per bed as the most expensive hospital built anywhere in the world? And the second question I have around that is accountability. Because, Mr. Costello, if you were asked by a client to build a hotel, and you were asked to build a high-quality hotel, but it also had to be cost-effective in terms of capital used, the money used to build it, and you turned around to your client about 2 years into the project and said, well, look, you know, inflation is awful, and we've underestimated the amount of bricks and wires and windows and beds and pipes we needed to use. So actually, you're going to have to pay for your new hotel twice as much as the most expensive hotel ever built anywhere in the world. You would be fired, your company would be taken off the contract, and there would be numerous court cases to find out how that happened. Can I ask, to date, as well as trying to understand how we will end up spending twice as much per bed as the most expensive hospital ever built, how many people have lost their jobs to date, and how many contracts, be they for quantity surveyors or MEC or ELEC or building or site clearance, how many commercial contracts have been cancelled due to these cost escalations? Thank you.
Thank you, Deputy Donnelly. Mr. Costello.
Okay, Deputy, I just go back to the benchmarking exercise first of all. AECOM are a reputable international company with a reach across the world in terms of the data that they collected. The information that they have given us is supported by facts and figures from a whole range of international hospitals similar to the Children's Hospital. And at the end of the day, the information they have presented to us, which we're happy to share and which can be interrogated, is that the average cost for building a hospital of the size and complexity of the Children's Hospital is €5,951 a square metre. And we're above that at 6,500, right? So that is the facts of it, right? And we're happy enough to have that information to validate it. In terms of the accountability, we are a very accountable group of people. Our board was appointed at the outset in terms of the skills that were required to deliver a project of this complexity and scale. We appointed an executive team headed up by John, and that across the board, in terms of the expertise that's on our executive team, it matches or is much better than what would be seen on any international project. So the project is managed really well. There's experienced people involved in it. We set about our work in a structured way.
You said that, and I apologise for cutting across you, which is my time, much towards the end of the time. So the specific question I'm asking is, how many people have been fired so far because of these cost overruns, and how many of the commercial contracts involved in this project have been cancelled because of these cost overruns?
In terms of the contracts, there was a very thoughtful approach in terms of how we went through a competitive bidding process. And at the end of the day, there are strict rules, EU rules, that govern procurement. If somebody, through a failure to deliver a project or to not deliver it in a safe manner, there are reasons why you might terminate a contract. There has been no basis so far to deal with any project on that basis, in the sense that we have now managed to have on our team, apart from our own management team and our own board, we have BAM, H.G. O'Neill and Mercury. They're 3 of the 5 biggest contractors in the country. We have the resources.
Sorry, just again, in the interest of time, Mr. Costello, has a single commercial contract been cancelled, yes or no?
No.
Has a single person?
No,
thank you.
There has been no basis.
Well, I can see plenty of bases. Has a single person lost their job anywhere?
As I said earlier, the
just yes or no?
Calibre. Well,
no, I understand the calibre. I'm not asking you the calibre. I'm asking you a very simple question. It's a very direct question. Has a single person lost their job? Yes or no?
No.
No. Now, you explained to a member of the committee earlier on that you got your quantities wrong to the tune of hundreds of millions of taxpayers' money. Hundreds of millions were added on because you underestimated the amount of things needed to build the hospital. But when you went looking to try and pull some costs back, amazingly, mistakes were not made in the other direction. You tried to find about 65 million in cost savings. You identified less than one third of that. So, for example, if you have commercial companies estimating the amount of equipment needed to build a hospital, and it turns out that they have massively underestimated, and that they have given you per square foot estimates that are a half of what they are now. Did any of these things trigger legal or commercial conversations where clearly there were very serious mistakes made in terms of design? You appear to have underestimated left, right and centre in terms of what was required to build this hospital.
It's important to understand that, and if you look at any, as we have done over the last number of years, looking at how large, complex projects are delivered internationally, it's a real challenging exercise. And that's why we have resourced this project.
Isn't it amazing, though, with all of the complexity? You're right, they are complex, but isn't it amazing the costs only seem to go up? Complexity never seems to mean that costs go down. And as the Chair said, complexity is difficult, but complexity can be anticipated for and it can be budgeted for. But it appears that complexity just means underestimation.
Yeah, but Deputy, in fairness, the management of complexity takes time. And that's why over the past 18 months, we have had the contractors working with the designers to make sure that all the complexity that's anticipated on this job over the next 4 years has been anticipated and is now at the risk of the contractors. So before we had committed...
But Mr. Costello, it's at the risk of the contractors now that the price has gone up. Like a fixed price contract works before the price escalates. It doesn't work after the price escalates.
In fairness, Deputy, it works when the complexity and the full quantum of the work is fully anticipated. And that's why the two-stage tender is internationally the best practice, because instead of starting a project of this complex nature and no clarity and no shared vision and no shared input into the design. So you start on this complex job and you work for the next 4 years. What happens, and it's not just once, it happens all the time, is that the contractors seek to improve their situation through perceived gaps in it. And the designers will never close all the gaps. So what we've done here is we've brought the contractors in early, and they've worked together to close all the gaps, and now the certainty before we actually have committed to the major part of the spend.
Thank you, Mr. Chancellor.
Thank you, Chair.
And Deputy Donnelly. Deputy Louise O'Reilly.
Thanks very much, Chair, and thanks to you all for coming in this morning. I think it's interesting, we just in teasing out the figures there with Deputy Donnelly. You know, it does strike me that we all know that there are cost overruns where that can happen, but this is on quite a monumental scale, really. I mean, if I was getting work done in my house and the costs were escalating at this rate, I'm not sure I would continue with all of those contractors necessarily. You do seem to have great faith in them to deliver, notwithstanding the fact that the costs just seem to keep going up. The question was asked previously, but I want to just get to the bottom of this. So, in terms of the additional capacity that will be added for sick children, and in terms of, and I fully appreciate these will be single room occupancy, and of course that's welcome. But given that the Irish Nurses and Midwives Organisation started only a year ago, I think just over a year ago, to count the number of children waiting on trolleys, so that would lead you to believe we have a capacity problem, which we clearly have. Am I correct in saying that the sum total of additional beds that will be added to the current number of beds is 4? Is that the correct figure? There will be 4 additional beds?
Deputy O'Reilly, I'm happy to answer that question. And I do agree with you that there are challenges in relation to the existing hospitals with trying to accommodate and meet the care needs. I just want to clarify, though, it is children's emergency medicine is different to the adult services. Unfortunately, like this morning, the children we have waiting, I know that the majority of them, bar one, it's isolation is the reason to why they're in the emergency department, not the fact that we actually do have beds up in the hospital, but because there are multiple use beds and because these children have influenza and other infectious diseases, we cannot put them into those wards. So there is an absolute crisis need to get this hospital built as fast as possible because of the additional need for isolation specific to paediatric healthcare. But to answer your question in relation to the additionality from the existing bed base within the 3 children's hospitals, as a total number there's 68 more beds, but it's important that it's broken down to understand that, because it's not just about numbers but the type of beds that we're trying to implement. The most important figure is that it's the inpatient and day cases, which are 44 beds, but within that there are new beds for mental health, new beds for child eating disorders, which we don't have, and probably most importantly, the critical care beds are 60 critical care beds. So just this is the largest critical care unit within the island of Ireland. It is going to have the paediatric critical care for all of the sickest children in Ireland, the cardiac critical care for the whole of Ireland services, because we're now providing cardiac services on an all-island basis, and it has the neonatal intensive care critical care beds. So that is a fundamental change. And where we in paediatrics have our greatest challenges is dealing with critical care needs and getting the really sick children transferred from the regions quickly when they need to be transferred, and also then it's the isolation requirements. And what's new then is that the other beds, which we are 24, are based within the paediatric outpatient urgent care centres and in the emergency department as short stay beds. We have actually demonstrated and put those in already into Tala, and this year we started with Temple Street. And I can report that even the children waiting for emergency, our access for admissions has actually reduced to 2018 to 2017 consistently throughout Trollygar because of these new ways of working. So what this hospital is going to address is for paediatrics the critical need for isolation facilities, which is higher in paediatrics than in adult services. And what we are doing is this year opening up the services at Donnelly. So by July we will be opening up an urgent care centre and outpatients at Donnelly. And this is the first time in North County Dublin we actually have paediatric services that meets the vast majority of the requirements for that population. And we have major pressures in this area, and we anticipate, particularly because Temple Street, so there's 124,000 children turn up to our paediatric emergency care services. 48,000 of them are actually into the smallest unit, which is in Temple Street. So we anticipate that from this year, the investment that's been made in paediatrics will actually bear fruit and reduce some of that pressures that are being experienced actually at Donnelly. And also we're dealing with a different way of working with our GPs, to whereby we hope to, which our plan is and has demonstrated, by having short stay beds we don't need to admit as many patients as we're currently admitting, so it should actually help with our bed capacity. And it's important because that's then happening next year in Tala, and then we bid to the hospital. So we have a very integrated phase approach to how we're going to transform services for children, particularly around the areas of general paediatrics, trauma, orthopaedics, which we've seen significant improvements in already with the investment that's been made in paediatrics, and of course our urgent and emergency care. So in light with the rest of the system in this launch care report, we are actually increasing the bed capacity, but we're doing it in a very niche way. It's not the same old. We're absolutely identifying and future-proofing where we anticipate the future healthcare requirements are. Thank you.
Thank you for that. I just want to make one very brief point. I don't accept, Eilish, that there are empty beds up in the house when there's people waiting and there's kids waiting down. But I will investigate that further.
I can get a report to you on that.
And if you could, I'd be very grateful.
Yeah.
Sorry, Mr. Costello.
Yes, sorry, Deputy. Just your first comment in relation to our confidence in the contractors. So the way that the contract is structured is that while we had given the first phase to BAM, during the second phase, if at the end of the day there was any reason that we didn't want to go forward, including at the end of the day when we checked out whether it was the best option for the project, we had the option of not going ahead with the contractor. And following all the interrogation we did, and then looking at, and I mentioned earlier on, it's on slides 18 and 19, and if you like, maybe John might go through that, looking at the different options that we had, it transpired that the option of going with BAM was, by a large margin, the best option in terms of cost and certainty. And while, given the increase in cost, our decision wasn't made lightly, but on the basis of the work we had done, we made a recommendation to proceed on that basis.
When you say it was the best option in relation to cost, are you suggesting that there are other people out there who could have contributed more to the massive escalation in costs? I find that really, that lacks a bit of credibility. Rather than, because I have read the slides, so rather than go through them, and I'm conscious that time is short. Just when you were at the initial tender process, did nobody ask any questions as to why one bidder came in €131 million below every other bidder? I mean, that would set alarm bells off. If I was, contracting to get a few presses put in, I'd wonder if someone was coming in that much substantially cheaper. You'd wonder what they were going to do. And now it seems that you went with the cheapest bidder. I don't believe for a minute, by the way, that there's other people out there who could escalate the costs at quite that rate, but perhaps they could if they thought they had a blank cheque for doing it. But you went with the cheapest bidder. The initial figure was just over 600 million. It's now 1.7 billion. And sure, look, none of us, nobody in this room or outside of this is going to be surprised if this reaches 2 billion. if this reaches €2 billion. So can you just, did no alarm bells go off? And just as an add-on to that question, Mr. Costello, you're 5.5 years in your position. So in that time, what sort of updates were you giving the Minister? Because the Minister relatively recently was out in the media saying that the 605, I think it was 605 million he believed would be the cost, and he was fully confident it was going to be delivered on time and on budget, etc., etc. It's now multiples of that and potentially multiples more. So with regard to meetings with the Minister, briefing the Minister, how many meetings did you have? What sort of format do those meetings take? Was he kept appraised of all of the cost overruns? And if I do have a chance, I want to go through the table that you gave us and just provide some detail as to how all of these figures were arrived at. But I'm just wondering, in terms of meetings, I mean, was nobody, like, if you weren't asking hard questions, was the Minister not asking hard questions? How this is happening? You know, this is a substantial amount of money, notwithstanding the fact that we do need the investment. It now appears that that investment may come at the expense of other projects also badly needed, but off the back of an assertion that the costs would be controlled and certainly wouldn't be escalating at this rate.
So, and I take there's a number of questions there, Deputy. So the first one was the bid was competitive. It was 131 million lower than the second bidder. Under EU procurement rules, it's very clear in terms of the pre-qualification of it, and at the end of the day, because of the complex nature of the project, we were anxious to get international bidders. So we were fortunate at the time. We had a short list of 5 bidders, and we made a decision on the basis of cost and quality. So it wasn't all just cost-based. With the criteria were 75% cost and 25% quality. We went through, before the bids were opened, we went through an assessment of the quality. And in fairness to all the bidders, the quality of bids submitted were truly outstanding. And then when the tenders were opened, then there's a very clear criteria in relation to how you make an assessment, and for that reason, in reality, you know, from once you follow the rules, then you award it to the bidder who comes through the assessment on quality and cost, and in that case, it was BAM. It was a competitive bid. Because of the way we're structured,
Do you accept now that competitive bid, maybe, and I'm trying to choose my words carefully, but what the former Taoiseach used to call smoke and daggers, was it not a? Do you accept now that maybe there was items that you wanted that were left out of that bid that ensured that that bid was the lowest bid? And you were obligated, is what you're saying to me, to go with the lowest bid. Now, to me, that doesn't make any sense, because what you'd want to be looking for is value for money. But if you weren't, and that's fine, you were going with the lowest bid. Do you now accept that that bid was maybe not the lowest bid in reality, but possibly just the lowest bid on paper, and that the persons who were tendering for that were clearly aware that you were going to go for the cheapest, and they gave you an estimate that really wasn't realistic? Like, because it doesn't stack up that you would go from the initial figure to the now current figure and to the who knows what the figure is going to be. That they would have known that. They're in the business of construction. I'm not, and I don't know if you are either, but clearly they knew. So they must have had a handle on how the costs could escalate. But when you were considering these bids, did nobody say, I'm a little bit concerned that one of these bidders seems to be an outlier in terms of cost, and I'm not certain that they will be able to deliver on this project for that money on the basis that they are so far out of line. I mean, 131 million euros is not a small amount of money. Huge amount of money. And if you think about the people who are working in the hospital, you think how long they have to work to pay the taxes necessary to generate that to be able to pay for it, right? So you're talking about massive amounts of money. So did nobody scratch their head and think, maybe there's something hidden here, or how is this such an outlier? It just strikes me as odd that you would simply go, the lowest price bidder is the one we're going to choose, and nobody sitting around the table questioned that. I would question that. If it was even a small household project, I would question that if there was a bidder coming in significantly below. And I'm just trying to get a handle on what was the thinking at the time.
Okay, so first of all, I actually am in construction, so I'm 40 years in the business.
With respect, that makes it worse, because you should have known then. I mean, if I'm engaging someone to do some work, I'm simply a householder. I'm not involved in construction, so maybe I could be forgiven for going with the lowest bidder, who then turns out to be 3 times the cost that they quoted me.
Yeah. So just in relation to going back to EU procurement rules, it's all set out very clearly in terms of pre-qualification, bidding, and how you select the preferred bidder. And there isn't much discretion for us, so we don't actually have discretion in that. So we can't say, well, maybe this is the way they're thinking. You can't use that discretion. The rules are set out very clearly. So we don't have the discretion you might have if you were doing, a project of a smaller scale that wasn't bound by EU procurement. Going on to just again to restate that the figure, the tender figure from BAM was 640 million, and we have now reached a position where, as we go forward and seek to complete the project by 2022, we now have programme and cost certainty on a figure of 890 million. And there, as it was at tender stage, the 640, it excludes VAT of 13.5%, and the 890 excludes VAT. And as John mentioned, that's one of the figures that's outside that make up the 1.433 at the end of the day.
To interrupt, if a bid comes in at 20% lower than the next bid, there has to be a reason why that bid is 20% lower. The person making that bid is using the same materials, is using the same criteria, but 20% is a huge reduction to the nearest bidder. So there must be a reason for that. And did you find out what those reasons were?
Well, there was lots of interrogation of it, and at the end of the day, there are different criteria whether it's a balanced bid. So if a contractor decides he's going to provide a square metre of block work at 10% cheaper than the opposition, it's very hard to say, well, no, you can't do that. Or he might say, well, because I don't have enough work, my workload is I'm taking a 5% reduction on the project overall. The reality at the end of the day is that contractors like BAM and all the other bidders, they're very professional companies. They would have put in several 100,000 of work in terms of preparing the bid, and at the end of the day, their bill of quantities was presented in a very professional format. So there was, on having gone through, and the reality is that the bids came in August 2016. We only finally got through the assessment in March 2017. So there's a period of 6 months that goes on through the quality and the price assessment of it. And unless you had very clear grounds, you will end up in court for 2 or 3 years. Like if a contractor decides that he hasn't been treated fairly. So in this case here, from a quality and a price point of view, the tender was really professional, as it was for the 4 bidders.
I'd say it was, because they were Lipton for a contract that is extremely lucrative. I asked you another question, Mr. Costello, just with regard to the Minister. At some point in the proceedings, you'd like to think that someone in the process was putting up their hand to say, hang on a second, let's ask a few questions. And if it wasn't yourselves, then maybe it was the Minister. So maybe you could outline for us, because the Minister had made public comment in relation to costs. He's now been entirely contradicted by the information that we have at the moment, and it remains to be seen how big that contradiction will grow into the future. How were you keeping the Minister appraised? How were you making sure that he was briefed? How many meetings did you have?
There's a very clear reporting structure. The board reports into the Children's Hospital Project and Programme Steering Group, which meets monthly, and that in turn reports into the Children's Hospital Project and Programme Board, which meets on a bi-monthly basis. So our reporting on a monthly basis is through what's known as a CHPNP, and John, in terms of the feedback from the boards, and it's all done in terms of the board. Like, we meet every month. In the case of, for the period from mid last year up to the end of the year, we probably met every week. And the reason we did was because for months, as I mentioned earlier on, it became clear that there was a challenge on the costs. First of all, we had to try and understand the basis of it, and then work with our own professional teams and our executive team, and with the professionals we got externally to review it, to ensure that, as I mentioned earlier on, that we weren't over-designing the building, and that the application of the Stage 2 criteria was being applied properly. So just if I might ask John...
Sorry, you yourself don't meet with the Minister then?
It's the way it's structured.
I understand the Oireachtas. So you don't meet with the Minister?
Other than, I mean, I meet with the Minister, sorry, in the forms, I meet the Minister when there are events, so actually I do meet with the Minister regularly. But the formal... I'm
talking about formal sit-down meetings with a calculator out. So if the Minister has a flashing red light going off and he is concerned about the overrun, or the catastrophic overrun, the monumental, whatever term you want to use on it, okay, so he will then go through that structure and communicate to you that he has a concern. Has he communicated any concerns to you in relation to the overrun?
It has been an ongoing since we flagged.
No, but specifically in the intervening time between when he made a statement about the cost and that has subsequently been contradicted. So in the intervening time, while the cost was escalating, did the Minister communicate to you, either through that structure, informally at an event when you met him, in writing or any other way, that he had a concern about the cost overrun?
As I mentioned, the structure is clear in terms of how the board communicates with the Minister through the CHPNP.
But just sorry now, and I'm not trying to trip you up. I'm trying to get to if the Minister had a concern and he wanted to relay that to you, were you aware that the Minister had any concerns, either through the structure or any other way? Any other way? Was it made known to you that the Minister had a concern? Absolutely,
and even John, if you say going back as far back as when we raised the issues around the sprinklers and all that, so that just it might explain how the structure works.
No, I don't want an explanation. I want to understand that if the Minister had a concern, had he raised it with you? If he had, did you respond to it? And that's not clear, and it's a really simple question, and it should be clear.
It's very clear. It goes back as far as late 2017, when the issue around the sprinklers were raised. So there was a 61 million I referred to earlier on, and when that was presented as a possible additional cost to the CHPNP, we got into a phase of 2 or 3 months of challenge in terms of what we could do to reduce, to ensure that we didn't go above the 983 million. So we looked at lots of different... So on an ongoing basis, there has been a huge challenge to keep costs to a minimum. And so the structure it's tough and it's robust
Yeah,
the
you'll
level of the
appreciate
board.
it doesn't seem that way to everybody. Chair, I have one more question and then I will save questions I have until after the break, if that's all right, in the interest of time. Mr Costello, you say that when you learned that of the level of the increase in the costs, your reaction was to commission an outside review. How much did that cost?
I can get the figures. I don't have it to hand here. But there were several reviews. So
no, I'm referring to the one that you spoke about in your submission.
We got a review by because the biggest cost increase related to the mechanical and electrical services. Our sense, first of all, was, well, maybe this is over-designed. So we commissioned one of the leading companies in the UK, DSSR, to do a full review of the mechanical and electrical services so that we could confirm that they were fit for purpose. And at the end of the day, and they have done a lot of similar projects in the UK, they confirmed that based on what we were setting out to achieve, a fully digital hospital, a modern hospital.
No, I really just had a question about the cost of that review, because you see how it looks to other people, and I'm very brief, Chair, you see how it looks to other people that, you know that phrase, when you're in a hole, stop digging, but when you have a massive cost overrun, if you try and spend your way out of that, I think that probably doesn't look right to people, but I would just appreciate details on the money that was spent on that.
It's important. Our designers, we needed an external professional view. And that was part of our due diligence, because the board took it, at the end of the day, the board took their decision really seriously, because we had the option, we actually had the option not to proceed with the project. Right? We actually had that option. And in a way that might have been an easy way out. We'd say, okay, it's too expensive, right? So we spent 4 or 5 months analysing this in every possible way, so that when we came to our board meeting in November, we could make a huge decision. It actually was an enormous decision, but it wasn't made lightly. It was made on the basis that, despite the fact that the building, the costs, the ultimate cost of the building was far more than we expected it to be, that we made a recommendation that we should proceed with it.
Sorry, perhaps I can get that figure at some point. That would be helpful. Thank you.
Deputy Alan Kelly.
Thank you, Chair. Welcome to our guests. This will be twice I'll be talking to you. I understand you're in front of the Public Accounts as well on the 31st. This is a huge topic of conversation over the period of Christmas and New Year, when us as politicians get time to reflect and talk to people for a considerable period of time. And this is going to be a case study for years to come. It's going to affect future projects, as the Chair has outlined very early on in the committee meeting, and it's going to have considerable impact on the future capital projects in health. I was a member of the government that made the decision to build the Children's Hospital, and it's the right decision. I was a junior minister when Eamon Gilmore and the Kenny set out about 400-odd million, 450-odd million, and then I was part of the government as regards making the decision to go ahead. I wouldn't have been part of a government to make a decision to go ahead with a Children's Hospital for 1.7 billion, because the impacts on other health capital projects would have been so dramatic. We'd have had to rescale it, relook at it. There is no way, I don't believe any cabinet would have signed off on it in any way, shape or form, anywhere near a figure like that, even half that figure. I note the Taoiseach's comments recently, where he said, when he was asking questions about the hospital, that he had to choose his words carefully, I quote, and he believes that the costs should have been anticipated. He talks about the model that was used, which is the first time it was used, to build something like this. And it's been done by a dedicated build board set up by legislation. So it's very disappointing that this has happened. that must concern you, obviously, that the Taoiseach of this country is, and I'd say he was being polite in his language because it was quite obvious to everyone in the chamber and publicly that he's extremely annoyed. And us as legislators, we're extremely annoyed. And frankly, personally, and I'd say I'm united with others in this, we're not going to stop until we get to the bottom of what happened here. We have to learn from this, but also we've got to get accountability because of the scale of overrun here. The public are enraged and they want to find out the whole decision-making process. So let me begin by, will you just remind people how you're constituted? And the reporting mechanism, and I felt you got very uncomfortable under Deputy O'Reilly's second and last set of questions. The reporting mechanism, just enlighten us as to how that works. So how are you constituted? You're constituted, I presume, as a public entity. Is that correct?
It's a statutory instrument. Yeah.
How do you communicate with one another as board members?
The board meets monthly. We have 6 subcommittees where people with the expertise and knowledge chair different subcommittees. So, for instance, John Cole, who's an architect and was previously head of...
How do you communicate with one another? Is it electronically?
No, we meet, as mentioned earlier, we meet monthly and then the subcommittees meet.
How is information shared between members of the board, is what I'm asking. Is it electronically?
It is, yeah.
And is that done under a consistent, dedicated MPHDB email address, or is it done using your private emails?
It's not private.
If I can answer that question. So we have an IT minute pad system in place where the board minutes, action items are all uploaded onto a hosted site.
The very simple reason is you're a public body. All information can't be outside of the circle of that body. That's all I'm asking. So all information is within the circle of that body.
Absolutely, absolutely.
And there's, as chair, you can guarantee us there's no information outside that.
Absolutely. And we're very mindful of freedom of information. And,
perfect.
Absolutely.
Now, you might remind people the reporting mechanism up as chair. Who do you report to?
So I report to the Children's Hospital Project and Programme Steering Group, and that the communication of that is through John, who's the project director.
Okay,
so
but who specifically do John or yourself report to? What's the person?
It's Dean Sullivan, who's the assistant director of HSE. So Dean is he chairs that group, and then the group above that, which is the CHP&P Programme Board, is chaired by Jim Breslin, who's the Secretary General of the Department of Health.
So the reporting mechanism is yourself or John acting as PRO, for want of a better word, communicate up to Dean Sullivan, who then in turn reports up to Jim Breslin, who's chair of the other. Is that correct?
That's correct.
Okay. So let's go back in, because I'm very interested in this. There's a number of milestones in this project which are critical decision-making milestones. Okay. Obviously, the awarding of the tender. Okay, which I would have huge concerns at the scale of the undercut by the contractor. It would set off alarm bells. I needn't bother going around, but there are examples of this across other smaller projects, even though there are large-scale projects in this country, which are well known. That's a critical milestone. Another critical milestone, obviously, was when this escalated up into the 983, whatever it is, million, and the decision to proceed. The decision to go for an award BAM Stage B of the contract is a critical decision and a critical milestone. And then, obviously, we have the situation whereby there was an escalation to the 1.4, whatever it is, billion, and subsequently the government memo, which is actually 1.7 billion. So, at all of these junctures, I presume there is documentation that you will be providing this committee, or if not, you'll be providing it to the Public Accounts Committee, about how you communicated that and the decision-making which will be in the communications up to Dean Sullivan, who obviously needs to come before the Public Accounts Committee, and to Jim Breslin. And will you provide the committee with all that relevant documentation in the next week or so, please?
Is there any reason we can't, John? No, that's
good.
No reason.
Thanks. That's a very honest answer. Thank you very much. Because the information behind those critical decisions, the information, this will, dare I say it, help yourselves, because from a transparency point of view, it will help us. But we just need to get to the bottom of this. But we also, on behalf of the taxpayers, need to get to the decision-making at the very top as well, from a government perspective, to proceed. So, and I know how it works at Cabinet, I've been there. So, those critical junctures, the decision-making, the documentation that went up to Dean Sullivan and subsequently, obviously, went up to Jim Breslin. When it comes to those critical decisions, when it comes to the decision to award the contract to BAM, the Stage 2 contract, what date was that taken on exactly?
The 5th of November, is it?
Yeah, can I, so our board at its board meeting, I think on the 5th of November, having at that stage determined, made the recommendation that the Phase B contract be instructed or awarded to BAM. Prior to that, it hadn't been. As the Chairman pointed out, we had the option of not to award if we believed that was the right thing to do. But having looked at where the costs now were and looked at the alternative options, this was by far and away the best option. So that was, so we recommended.
How was that communicated is what I'm really asking.
We issued a report with a support recommending to the HSE through Dean Sullivan to that our recommendation of our board was to award the Phase B to BAM.
I understand that the first the HSE knew about this was in around middle of November. Would that be correct?
As
there was a meeting in the HSE around middle of November, which was absolutely mind-boggling to them. As politicians, we deal with the HSE all the time. I mean, I've been warned for months that the 50-bed unit in Limerick Hospital, the 60-bed unit in Limerick Hospital, 50-bed unit in South Tipperary, both Oireachtas and my constituency, the national maternity strategy, rake of other issues in relation to primary care and all that. You might as well forget about them, lads. They're gone. And they'll be profiled as how the politics of this will work. They'll happen, we'll announce them, but they'll be profiled out over a number of years because of this overrun. So, as regards to communications of that, that went up through the system to Dean Sullivan on that date. Is that correct?
It would have been after that day, because that was the date the board meant, so certainly within maybe a week of that day, the recommendation was issued. And
so, and obviously Dean Sullivan isn't here, and in hindsight, Chair, potentially we should bring him next week. I know I'll be recommending that to the Public Accounts Committee. So obviously that would have been then communicated up the line to Jim Breslin pretty quickly, I would presume.
John, would we mind just, because Deputy Kelly had said that the only communication HSE had was in November, so you might just give
If that's not accurate, just tell me.
Yes, that's what John suggests.
Yeah. So the contracts were signed in terms of the Phase A works, which is the underground works. That's the bit that BAM were initially instructed to get on with and have now nearing completion. So contracts were signed in August of 2017.
Where?
And they commenced works in October of 2017. At that stage, we had the grant of fire certificate from the fire officer, which had imposed the requirement of sprinklers to put into the building. We appealed that decision because we said it's far in excess of what the current building regulations stipulate, and the inspector's own, Bord Penola's own inspector confirmed that in fact we were already in excess of the building regulations, but notwithstanding that, Bord Penola determined that we should put sprinklers. So in late 2017, we anticipated that decision could come, so we costed those. We had, prior to signing of contracts on the urgent care centres at Connolly and Tala, two of our specialist contractors, mechanical and electrical, got into financial difficulties. So one was into examinership and another was liquidated, so we had to revert to the second-rank candidates. And also prior to signing the contracts with BAM and Mercury and Joneses in relation to the mechanical and electrical, we had to align our programme. So late 2017, we appraised the CHP&P steering group and the board of 60 million of additional costs.
60 million?
60 million.
So the department, Jim Breslin / the Minister, I presume, would have been aware of that late 2017?
Correct.
That's fine. That's not the issue that I'm concentrating on.
I was going to follow on.
Oh, yeah. Okay, well, we're kind of covered.
Yes, sorry, Deputy. So we then we continue to working through the two-stage process. That's closing out with our designers and our contractors on a package-by-package basis. What's the final cost? The trending for that up until last year, mid-2018, our design team were confirming that we were on budget, that there were no significant, beyond the 60 million that we'd previously...
What date was that?
That was up till about the middle of 2018.
Oh, dear God.
So at that stage then we were starting to complete the packages around mechanical and electrical. So it was in August 2018 when the design team were reporting a very significant cost increase. We're now roughly at a figure of maybe 200 million from the 60, so it increased by a further 140 million. And we briefed the HSE at that stage, and we briefed the department at that stage.
So that was August 2018?
That was August 2018.
Obviously, there was no comment from the department at this stage. Okay, so that's 140 million more. So when did it escalate up from 200 million again? So
the direction of the board is we needed to conclude, it's our board, that we needed to conclude the two-stage process, that we needed to go back and determine what are the final costs, and in parallel with that to look at what are the alternative options. Is there a better procurement option out there? So we told our design team, conclude the process, bring it to a conclusion. That concluded the end of October, and we brought it to our board at the November.
And that's where the 400 odd million.
Correct. That's when.
So between the end of August and October, so 2 months. So it gone up by 60 million. Then it was up by another 140 million, and by the end of October it was up by
450 million total. Yeah. Well, it's 320 million. I'm talking figures net of that.
Yeah.
So it was 200. Yeah. So it was the end. I say it was at our board meeting early August. We meet on the first Wednesday of every month.
So the Department of Health were aware of a 200 million extra by August 2018, and by end of October and / early November, your board meeting then subsequently obviously would have went up. It was 450 million.
Yeah, it's just important that, as John says, the 200 deputy was construction costs only. So we were reporting on, because we were going through the stage 2 process, the report.
And that's why, and then with the electrical and stuff, that's why you say in your conclusion, after lessons to be learned in pursuing core reductions and competitive tenders, in particular mechanical and electrical services at tender stage. That's what you said in your conclusion.
Yeah, and because at the end of the day we recognised that the complexity of the mechanical and electrical services hadn't been fully defined at the time. It's also important, Deputy, to remember, like we talk about cost overruns, and when we say we're deeply disappointed about the outcome of it, we're disappointed because of the fact that at tender stage, the ultimate cost of doing the job was underestimated. And we're disappointed because of the impact it has on other projects.
I know that. I mean, you said that you wouldn't change it. You wouldn't change how you did the tender, or you wouldn't change your decision making.
Correct, yeah.
Yeah, I have serious problems with that, because we're in virgin territory here. We've never done this before. And that's why the phrase best practice isn't applicable here.
Well, it's
no, one second. I don't accept international best practice, being honest with you, because the circumstances, when it comes to best practice, you're not comparing like with like. It's not apples and apples, oranges and oranges. Complete different jurisdiction. Complete different jurisdiction. So there is no best practice. This is the first time ever. And frankly, obviously, we've massively failed. Now, obviously, there's learnings here, but best practice doesn't cut it. Same we're delivering the best children's hospital doesn't cut it. I mean, that's the line that's been thrown out at political level. It just doesn't cut it, because the consequences are catastrophic for other capital plans, catastrophic for people's health in this country. Okay, I want to just, and I will come back. We need to get into the whole decision making to proceed with BAM based on the fact that they completely undercut, or they were so far under everyone else, and yet the decision making to proceed and the escalation of costs. And the 983 million didn't include ICT, EHR, family accommodation and a whole range of other things. I'm not sure politically how people were aware of this. They weren't aware of it. They weren't aware of it in any way, shape or form. I mean, when the announcement was made that there was 650 million being spent on the hospital, that was cutting the ribbon. That's what people thought. Others, obviously yourselves, would have a different, but I'm telling you, that's what 95% of the people inside here, if not more, and the public thought was happening. I have a specific question in relation to governance. In relation to the actual spec, in relation to the request, and you said in a number of answers to questions, obviously the costs escalate because of the specifications, the requirements, the tightening up in relation to Phase B. The requests for facilities that were being put forward by the current hospitals that are part of the group that are coming through, how did you validate the requirement for the scale and expense of those? In each and every request, I, in the future, want to see the requests, want to see how they were validated.
Specific, John, on that.
So the hospitals that have been coming together to create this, they obviously have requirements. That's fine, right? How did we validate the scale of them and the necessity of them and the cost of them?
Yeah, maybe I might just take the...
Deputy, thank you. So what we did was we assessed the activity and capacity that would be required in the new children's hospitals. So we have the 3 Dublin children's hospitals. So we collected the data of their current activity, and then there was an exercise done by health planners.
Many beds, by the way, is there in the 3 hospitals?
In the 3 Dublin children's hospitals at the moment there is 350.
350?
Yeah.
I understood that they had considerable more.
This is just talking. The 350 is the inpatient beds that we actually have. I actually got the data here, and I can share it actually with you.
Okay. Okay, go on.
In relation to that, so we have 350 beds, of which there's 189 in Crumlin. There's 45 in Tala, and there's 116 in Temple Street.
They're inpatient beds?
They're inpatient beds, yeah, just to be clear. And then our day beds are 79, of which there's 44 in Crumlin, 10 in Tala, and 25 actually in Temple Street.
And they all have full occupancy?
Yeah, most of the time, except we do obviously.
Okay, can I ask you to do an equation for me, come back to the committee. Go back the last 3 years, get the total amount of beds that are in circulation in the 3 hospitals, divided by 365 as regards occupancy, and also day occupancy. Because remember, we have weekends here. And come back to me with the figure. Okay. And then, that's what's the requirement in this state. And then we'll see where the 473 figure is needed or not.
I think Deputy did there is healthcare planning.
I agree. And with population increases.
Correct.
Yeah, and all of that.
Oh, you want? Yeah. So we have a whole.
No, I don't want that. Okay. We'll figure that bit out.
Yeah. Okay.
We'll fill in the gaps. do the equation I asked you to do, if you wouldn't mind, and then we'll see what that figure is, and then we'll look at the 473 and see is this hospital the requirement, and then we'll allow for future planning, future population. Because remember, with the advent of sláinte care, ICT, all of this sort of stuff, with the 2 centres outside, I can't see, we've got to look at the scale of what the decision making as regards the requirements here. Because this is where costs go.
No, absolutely. I think it's useful if Emma could just give a flavour of how that decision was made and how the scope of the project was defined, because ultimately that's the starting point.
As you say, it was based on current activity and then population growth and immigration taken into account. Then we looked at, currently there's a very significant unmet need. There are very lengthy waiting lists. There's 45,000 children waiting to be seen in an outpatient clinic, 17,000 of those waiting longer than a year. There's probably a 12 to 18-month waiting list for an MRI scan for a child. So there's very significant waiting lists for children who are waiting for non-urgent surgery, so elective surgery. There are extremely lengthy waiting lists, sometimes 20 years.
And I'm glad to hear all this. All I want to do is, let's do the equation. We know what the final figure is. And then, if you wanted to produce a completely separate document which outlines what those are, and presumably that will fill in the gap.
Yes, we can do
right?
that, certainly.
And we can judge then if the gap filling in was the correct procedure. And I have one last question then, if that is all right. A specific question, and I'll come back in a second time. A specific question in relation to private practice. What facilities are in the hospital are being built to be used for provide for care and treatments for children by clinicians in a private practice, and what is the cost?
You want me to respond to that one, Deputy? So the new Children's Hospital obviously is 100% single room, so there is no differentiation made between what we'd have maybe in adult hospitals, a private ward versus a public ward. According to because of the current contract for consultants that we have actually in the hospitals, they have B contracts, which means that they're entitled to actually do outpatients in the hospital. So we have 9 outpatient suites that actually are meeting that requirement. Paediatrics is considerably less, have private practice compared to actually adult. And I'd have to bow to John to actually know what the construction contracts of that are. But it is very small, and it is in meeting the contractual obligations that we have in employing those consultants.
Okay, John, what's the quantum amount?
I think my recolletion is, could we did this exercise before, it was about 2 million, but I'd need to check the figure for you, but that was my recollection at the time.
That's fine. I'll come back in again. Thanks.
Thank you very much, Deputy Kelly. And now, thank you for your indulgence. Senator Burke.
Yeah, thank you very much, and thank you for coming forward with the figures here this morning. I think it's important, we're talking about 6,000 rooms. Maybe we might get a breakdown of how those rooms, we've already talked about the number of beds and the number of daycare facilities, but maybe we might get a breakdown of the number of, how are we talking about 6,000 rooms? Because I think the general public out there think that's all being built is just 470 rooms for a hospital. I think 6,000 rooms is something that I'd like to see some clarification on. How is that made up? What are the rooms for? I understand that there will be need for medical personnel, but how many, for instance, maybe it might be helpful if you gave us an idea of how many clinics would be running at any one time there when this is up fully operational, taking into account that we have 6,000 rooms, and just that's just my opening question on this.
Eilish, would you mind just give a sense?
Yeah, so I think we can give you a full report, because you actually have that, so that's no problem actually sharing that to your sense. But so how we deliver services in paediatrics, it's important to understand that actually the vast majority of the service we deliver is outpatient based. Yes. And emergency and urgent care. So you will note that we actually, in the planning for this hospital, have seen significant increases in how we're providing outpatients. So So we would have a total of 141 outpatient rooms, and they are spread between the centre, the outpatient centre at Donnelly and Tala, as well as the new Children's Hospital. Because the vast majority of services can and should be delivered in paediatrics on the same day through outpatients, and that reflects again how we're moving with Sláinte Care to much more nurse-led and health and social care-led, professional-led clinics, not just consultant-based clinics. So what we have done is we have looked at as we say, the activity and planning, and we've projected the future requirement needs and mapped those into those particular rooms, and we can give you a breakdown of, because it is by different specialties. And just to give you an example, so some of our clinics are very short, like trauma, fracture clinics, it's usually a one-time visit. But because we are dealing with the 25% of the population are children, because we're dealing with all of them that have high-end, the tertiary, quaternary needs, the high-end specialties, many of those have multiple appointments. Sometimes they come to our hospitals and spend the whole day going within the different specialties. And actually some of them, like our cystic fibrosis children, at the moment, when they come in, they take up the whole day in one room, because we don't mix our children with cystic fibrosis, because for obviously infection control reasons. So sometimes one child can take up a whole day of clinics. So it is broken down to take into those niches. But again, our activity and planning can actually map that. But I think for a children's hospital, it's important to note that it is different to an adult hospital, and it needs an awful lot of auxiliary supports. So within that, we also have for example, we have facilities for parents to actually stay in the hospital close to the critical care, what we call within dressing gown distance, because these mum and dads and other family actually are with very critically ill children, and we need to support them, which is different. I think it's also important to note that this is the only hospital that is actually going to be educating the future healthcare professionals in paediatrics. So that is all of the undergraduates in medicine and nursing and the health social care professionals will actually be based here. So it also includes the education centres to actually facilitate that that we have developed with the universities, and all 7 universities actually will have some association with those hospitals. So that has to be taken into account. And then within just the sheer supports that's actually required, and we have actually prioritised in our planning to ensure that all the clinical requirements are met, and we have sought and optimised the support structure. So because that was one of the benefits of being co-located on a large medical campus that is at St James's, which is a 50-acre campus, we actually have managed to drive some efficiencies around that, whereby through shared services, where we're utilising services that are for the whole of the campus, not just for the Children's Hospital, and we've actually built in capacity to take on the maternity hospital as well. So I think all of those factors need to be taken into account.
But I think in fairness, trying to explain to the general public that there are 6,000 rooms,
yes.
Maybe, you talked about 141 clinics. Are there some of the rooms going to be attached to those clinics that are going to be used? But it's just, I think, if we could get some kind of breakdown about the 6,000 rooms, it might be helpful.
Happy to do that. And
there's a general public out there who are thinking of, the number of beds, full stop, and it's costing so much per bed, where in fact we're talking about a whole lot of additional facilities being provided there as well. Absolutely.
For example, even the assessment areas in the emergency and urgent care centres, there's 54 assessment areas. They're really important, because that's how we actually get the children in and out and through in a timely manner. So we have 10 assessment cubicles and they're all single as well, just again in keeping with the nature of paediatrics needing isolation. So there's 10 in each, even in the satellites, and there are 34 of them in the emergency department. So even with all of those, there's treatment rooms and other supporting facilities that are important. And just maybe to assure the committee, we have had 3 external reviews of our activity and capacity. These were commissioned by the HSE in our early stages of planning to test the robustness of the clinical planning and the requirements, which actually just to give assurance about what the requirements are. But happy to break them down and demonstrate how much of this hospital is around clinical. But I do need to add, I mean, this is very complicated because even the 60-bedded critical care ICU is the largest ICU. There's a lot of support rooms that are needed around something like that, even mechanical and electrical, that are required to do it. But we can happily break that down.
But it might be helpful as well if you might give us an idea of the number of people who are likely to be going through outpatients on a daily basis.
Yes.
Have we figures for that?
Yes, we do.
Because we're talking about 3 hospitals combining.
Correct.
So while we have the individual figures for each of the hospitals at the moment, it might be helpful on a day-to-day basis.
Correct.
What numbers will now be going through per day? Have we got any idea of the kind of figures we're talking about here?
What I have is the total activity projections. That's what we're to do, and they are actually, we do anticipate significant increases in that, particularly because of, as Dr. Curtis has already identified, we have significant challenges around some of the access to paediatric services. So we understand and have anticipated that the activity for our inpatients is going to go up to about 24,000 inpatients through annually, and then for our discharge for our day cases, that's also up to about 26,000, and we anticipate that there is going to be over, I think it's 124,000 are our emergency department consultants. But I can break those down into daily rates and what we're anticipating.
I think it would be helpful because I think that might then give an idea of what the hospital, the service that the hospital is going to be looking at, because people are now looking at just the number of beds where there's a whole lot of huge amount of additional activity going on there, and I think it would be helpful when looking at the overall cost of this project.
I mean, even Senator, to take a comment, this year alone we are opening up the Paediatric Outpatient Urgent Care Centre at Donnelly, which actually is going to significantly help our current challenges. So we know that we have challenges in relation to outpatients access. So this year alone there's about 7,500 extra outpatient facilities that we will be able to offer. So we will see the benefits of this investment starting actually this year, and with other service developments, because this is about, which we shouldn't lose sight of, transforming how we're delivering services to children. And while we're cognizant of the investment involved from the Children's Health Ireland perspective, we're confident that that the public and the people we serve, which are the families and children, and the taxpayer, that we will see the benefits of that investment starting from this year.
Okay, can I come back to Mr. Costello, and that's in relation to the initial tender by BAM, which was 130 million less than the next submission or the next contractor. Just in relation to that tender, obviously there was documentation issued to each of the contractors as to what was required, and then when the tenders were submitted back, am I right to say that there was a bill of quantities coming back as regards how the costing was broken down? What I'm asking is, was the bill of quantities as regards what was contained in them, not as regards price, but as regards the actual listing of each item, the same for all of the contractors, or was there a variation? And did that variation mean that the cheapest tender could then, because they were including less in their tender document, as a result then were able to tender at a cheaper price? So I'm just looking at, we need some clarification. Other people have raised this whole issue. And by the way, I have been involved in arbitration in relation to building disputes, so I'm very much aware of cost overruns, and where something is not specified, it's an additional item, and normally it costs about way more than what would have been originally tendered for. So I'm very much aware of having gone through the arbitration process on a number of occasions in a legal capacity. And I know from your own experience you would be very much aware of the arbitration process as well. So I'm just looking for some clarification on that issue.
Thanks, Senator. And on the reason we went on the two-stage tender. I know Deputy Kelly is out of the room now, but it's not the first time two-stage tender has been worked. It's been used by the NRA in ECI contracts. It's used in NEC contracts. It's used widely in the private sector.
Yes.
But in this case here, we made a decision to get our quantity surveyor to prepare the bill of quantities. So it's not prepared by the contractor. So everybody is working off the same basis. There's a bill of quantities went out to the contractors, and at the end of the day, there was a check done to make sure there was a fair rate applied to every single item. And you'd know from your own experiences, whether a square metre of block work is €15 for a 4-inch block or €20, it's hard, somebody will argue, oh no, that's all it is, or it's so. But at the end of the day, when the check was done on all the bills of quantities, it was deemed that the tender from BAM was balanced. It was competitive, but it wasn't below cost. I mean, it was actually deemed to be a reasonable tender and supported by a really high quality bid so it wasn't just, they weren't just bidding on a bill of quantities basis. They had to set out how they were going to approach the job across all the different disciplines of health and safety, environment. And one thing that's on the positive side that was prescribed here is in relation to the local community benefits package. So we've always set out here that the project should be a legacy project. It's of such a scale, it should give a legacy. It should be a legacy for obviously childcare in the future, but it also should be a legacy in terms of the local Dublin 8 area and the city generally. So within the contract were things as diverse as the local employment benefits, but the quality of the submission that came back from BAM and indeed the other tenderers was outstanding, and then that supported their commercial bid. But just to confirm, at the end of the day, the bills of quantities that was being priced by each of the bidders was the same bill of quantities.
Okay. So when you then sat down to look at the overall contract and all the additional items that needed to be put in place, and say for argument's sake you had taken the second highest bidder and started working with them, would your in fact cost now be far higher than what we've ended up with at this stage?
It would actually, and the reason is that a lot of the additional cost here is in the mechanical and electrical services, and while we've had a lot of discussion around the main contractor and the fact they were a competitive tender, a lot of the additional cost here is actually in the mechanical and electrical packages. And people should have comfort, and we're happy enough to share this information, is no more than the rules of EU procurement are very prescriptive. The whole rules around the stage 1 and the bill of quantities and the development of the stage 2 process, and ultimately the finalisation of the contract price, it's very prescriptive. It is the revised quantity and the bill of quantities, which is prepared again not by the contractor but by our quantity surveyor. And you'll be familiar with this, Senator, is it nowadays with the benefit of BIM, which is Building Information Modelling, and because of the complexity of this, the BIM model in essence takes the uncertainty out of it. So the BIM model will actually prepare the bill of quantities in association with our own quantity surveyor. So there can't be argument over saying, well, I measure this and it's X and I'm Y. The BIM model actually will verify what the quantity is. So the ultimate quantity of every element on the job is absolutely clear. Ultimately somebody can look into this BIM model, which is really complex, but if you want to press a button and say how many single doors are in it, actually the information is there. So there's nothing sort of ambiguous about this. Another thing that's important is that, of course, there were some arguments, right? But within the contract was agreed that this independent expert would adjudicate on those, and his finding was binding on both parties. So at the end on the list here, there is an amount there of 22 million, which is the outcome of where the contractors had claims for entitlements that they saw. But they are predicting all the challenges that's going to be on this project for the next 4 years. So they obviously did see they were protecting the risks, but ultimately there was a process in place through the independent expert to deal with those.
But could I just ask one final question?
Senator,
but
yeah,
could I
do you want to bank your questions until after the break, or are you happy to keep going?
No, it's just one, just one simple question. Could a lot more have been put into the original bill of quantities that was sent out to builders than what was put in? You know, when you're talking about the additional cost because it's associated with mechanical and engineering, or mechanical and electrical, could a lot more have been put into the original bill of quantities when tenders were invited day one?
That's a fair question, Senator, and that's, say, one of the lessons learned there is that the complexity of the mechanical and electrical services, and across the M&E services there are actually 24 different systems, whether it's from ductwork to pipework and medical gases and all of that. So yes, at the end of the day, we did go, what is in there, and people can comfort and assurance of it is, at the end of the day, every element, and I mentioned earlier on, of the 5,500 kilometres of cable, there's all different sizes of cables. So we have rates for all the different sizes of cables, but the quantum, because the design was at an outline stage, and as John mentioned earlier on, with a digital hospital, the complexity of not just having a socket on the wall, but it's how the cable is distributed within the whole building and back into the data centres and the switch rooms after that. So there was a huge complexity about that actually took 2 years to develop. So we went out to tender in June 2016. We eventually had the mechanical and electrical design completed in mid-2018. So an option which we did consider back in 2015 was to go on the basis of completed design, then go to the market. Right. We'd be going to market 2 years later.
That's right.
And in a time when there's high inflation. So, okay.
Thanks. Thank you very much.
Thank you, Senator. So we'll take a break for 15 minutes, so we come back at midday, 12 o'clock. Is that okay? Thank you. So meeting adjourned until 12.
The cost of a project. There's just one or two questions that I would put. First of all, in the number of tenders received, the difference between the lowest tender and the highest tender was, just remind me what it was, and in a minute, and the extent to which the spec was observed in each of them. The other question, Chairman, is in relation to the 890 million, plus the ancillaries that affect other locations and sites. Is it likely to increase the cost, to increase further under any of those headings? And if so, to what extent? And I'm talking about the 1.4 billion eventual. And to what extent can it be retained at that? Can I also ask, 890 million excluding VAT, I thought there was some clause somewhere that VAT wasn't chargeable in some state projects. And how does that apply to this particular case? If you're building local authority houses, it doesn't anyway. and maybe we could get some clarification. And how much would that be? Well, I don't want to get out the calculator, it's not too difficult a job, but it is a contributory factor. Could I ask also, were the various bids in any way date conditioned? It is usual in many cases to say that this particular bid will last for a particular time, and what then is applied thereafter, what will it cost afterwards? And is the project in accord with international norms in relation to the specification for hospitals of different categories, whether it's a category A, B, C, or whatever the case may be? And I say that, Mr. Chairman, on the basis that if we want a state-of-the-art hospital and we want a world-class, and the parents of sick children want nothing less than a world-class hospital, then we need to be careful not to dumb it down before it starts at all and create a situation whereby we expect to get it at half price. It won't work that way, and we won't get what we're looking for if we're looking for the highest possible standard in terms of care for children, for sick children in the future. Was it possible? I know that the bill of the quantity, the QS would internally, your own evaluation of it would show, and did it show, and to what extent did it show any discrepancies, and was the discussion take place vis-à-vis the various tenders? Were they compared? How were they compared? Was it pointed out that A or B or C included more than was required or less than was required, and so on? And was there a provision or request made, or any clarification as to a general recognition of inflation on the various building works, whether they be electrical works, whether they be building construction works, or whatever, and what were they? Were they marked off as being of a particularly sensitive nature? To what extent were they likely to change over a period of years? And my last question in this tranche would be, to what extent were you, the evaluation team, satisfied that what you were dealing with now was the best that could be done, and that there wasn't as it were, an upstaging of your efforts by any body, any of the involved bodies, seeking to increase the cost, extent, scale, or value of the project, other than what you required yourselves? And could I mention as well, I know that your group spent some considerable time since July last year considering what was going to be done next, when you discovered that there was a price overrun. By what amount did it overrun in the period between July and, as it were, November or December? Because it did. There definitely was an overrun during that period. And my question would be, was it wise to delay at that stage, other than by simply saying, this is there are cost increases here, they're in excess of what were anticipated. And could I ask also, at every level, were there cost levels anticipated and potential increases identified at an early stage, with particular reference to the lowest, middle or highest bids? And can I also say, in that context, whether or not you remain satisfied at all times that all the tenderers had in mind were at idem with what you were about, in other words, providing the most efficient, effective and cost-effective building and facilities in line with the specification and the regulations appertaining to what you were doing.
Mr. Costello.
Sorry about linking them all together, Chairman, but can't help it.
Okay. Deputy, thank you for that. I'll just start, and there's probably 7 or 8 questions there, so I'll try and deal with them. If you don't mind, John, if you could deal with the one, that challenge of would it have been wise to delay, and the exercise we did looking at the options. I think we haven't dealt with it earlier, so it's good if you could talk to that. Yeah.
So, back to the Deputy's question in terms of, so it was about the middle of 2018 that at that stage the trending, the cost overruns issues were starting to arise. So at that stage our board requested that the executive go back and look at alternative options for the project, conscious that we didn't have to award the Phase B works to BAM. We had that option to say complete the Phase A works and we can go back out to the market. So they didn't have any entitlement to get the next phase of the project. So it was very important for us to conclude the process of the 2-stage, to bring it to a conclusion, to say definitively what is the overall cost of the project, and in parallel with that to look at what are other options. So we looked at 2 other options. One was we now had a totally completed design with all 6,000 rooms fully designed and detailed. We had a fully detailed specification, bills of quantities, everything had now been itemised out. So we could have gone back out to the market with that and re-tender the project and said to the BAM that we're going back out to the market. And the issues with that were that it would cost a further 300 million. That's additional to the 1.4 billion we're reporting here today. And it would also delay the project by up to 2 years. So we looked at a traditional model of procurement going back out to the market, and we looked at a construction management model of going back out to the market, which might save us some time, but this hadn't been done under the public service, public construction contracts. So, and also increased risk would fall back to the client. So having done that evaluation, it was clear that by far and away the best option remained, notwithstanding the cost challenge it poses, to award the Phase B to BAM. The HSE also carried out their review of that process, so we carried out that review ourselves internally, and the HSE carried out their own review, and we met with the HSE and we presented over 2 days challenging whether that logic still held up. But the recommendation clearly was it would delay the project longer and it would cost more. So the best option in terms of procurement is to award the Phase B at that stage. And that was the decision our board made in November 2018 and was subsequently then approved by government in December.
So, sorry, Deputy, you asked what is the difference between the lowest and the highest? So between the lowest and the highest was 180 million.
So it's probably worth, so we got, so to attract contractors to tender for this price, we were conscious of the need to get both Irish contractors and international contractors. Because there was a limited number of contractors in Ireland who could take on a job at this scale was limited, and we wanted to make sure we maximise competition in the marketplace. So we went to the UK to meet with contractors and meet the buyer events there, encouraging them to tender for this project. So then we shortlisted 5 companies to tender for it, but notwithstanding we shortlisted 5, in the end we only received 4 tenders, and the perception was people would be falling over themselves for a project of this size, but we received 4 tenders. But it was very important for us that we had managed to get international contractors. So we had 3 international contractors made our shortlist, which very much send out a message to the marketplace. This is a competitive process. You're going to be up against high quality companies from abroad, so which obviously delivered a competitive price at the end of the day.
And Deputy, then in relation to a fair price, or that none of the contractors abused their position, which they couldn't, as John says, in any case, because we didn't have they didn't have an entitlement to the contract afterwards. But the procedures were very clearly set down in terms of how you get from the stage 1 to the stage 2. And in essence, as I mentioned, it's through the contractors and the design team working together to develop the design to completion and to de-risk it, because risk ultimately comes back to the client. What we're pleased to see is that the HSE now have commissioned a review of the stage 2 process and the determination of the final cost, and that's due to start next week and will be carried out over an 8-week period. So as well as the due diligence that we have done ourselves, that's another level of due diligence that will happen on top of that. And the other one you mentioned in terms of an evaluation of the tenders. So our quantities affair goes through the bill of quantities line by line for every item, and they do an analysis, in this case across the 4 bidders, seeing were there any outliers in terms of costs or the percentage add-ons or whatever, and then before we made an award, and that's why the process does take a long time from when the bids went in October 2016 to final award in February 2017. There's an opportunity before the contractors know where they're placed is to seek clarifications. So in the case of each of the 4 bidders, there is a very detailed questionnaire in terms of looking for clarification document that goes back from the quantity to each of those, clarifying what might be perceived and looking for clarification. And for instance, if an item didn't have a price, was that deemed to be 0? And so that there is a whole due diligence that goes on around that. So that there was a very robust process that went through that in terms of making sure at the end of the day there were aligned. And in the case of the lowest bidder, because they were very competitive, naturally their tender got a lot of scrutiny to make sure that there were no gaps in it, and if any were, that they were clarified to make sure that as we went on to stage 2 afterwards, that the information that was in stage 1 supported the proper development of a final price.
The VAT.
The VAT,
Oh,
yeah, I'd be happy to take that question. So the total VAT for the project out of the 1.4 billion is 180 million. And that obviously is a circular tax which ultimately returns to the state.
That element of it, Mr. Chairman, is not a net loss because it returns to the state.
Correct.
Right.
So your question was,
how is that included in the contract then? Why is it included in the contract? If you build local authority houses, that is not charged. My understanding, or it's set aside as a contract.
well, certainly, like we did as part to see were we exempt from that, and we also looked to see was there any exemption in terms of planning charges, and we're not exempt from either of those. So we have to function exactly like a normal commercial organisation in terms of reporting on that and planning contributions.
All the tenderers, Mr. Chairman, initially were they aware of the 2 stages to the contract?
Oh, absolutely.
Yeah. And what are the variation? What were the variations between them then, as the first stage to completion? And the second stage to completion. Were there any obvious differences that showed up there? For example, was there an understanding that the person who got the first stage would automatically be in a good position to get the second stage, or was there a pricing element that various tenderers might have included in the view of the fact that they might not get the second stage?
So just I mean, it's awarded as one contract, but if we cannot reach a satisfactory conclusion of the stage 2, we can opt out of it. So the expectation.
Without penalty?
Absolutely, yeah.
And did you consider doing that?
We absolutely did.
And for instance, you evaluated the cost then of the second stage. Suppose you took the lowest of the tenders in each stage separately. What would that give you?
Well, you don't. I mean, for months an award is made. So under the EU procurement rules, for months you make an award, which would have been in February 2017. That competition sees. So it's not like you don't have the option of going back to the second or third bidder at that stage. So
no, but that's not what I'm suggesting, Chairman. What I'm suggesting is that when initially, did you said yourselves that you could have stopped the contract after phase one and gone back to the bidders again. Isn't that true?
Well, you could. No, you'd have to start a completely new process, and that's what John just set out.
Right. Okay. But could you have initially, in awarding contracts, when they were evaluated, could you have said, okay, we're taking stage one from contractor A, and from continuation by contractor B?
It's not the way the two-stage works, really.
I'm aware it's not, but could you have done that?
Well, not. It's. I mean, part of the process is the contractor is engaged on site in doing the phase A works, right? And that at the same time, for in this case here, for more than a year, then the contractor works with the design team in developing the design, and then on the basis of the quantities that come out of the completed design, you evaluate the final price, and it's at that stage, as John, and if you want to just go through it again, John, just to sort of finalise or clarify
and don't forget the date restriction or date conditions that might be applied to a tender.
Once we received our tenders, I say, and we tendered in 2016, and BAM were the lowest contractor. The recommendation was to award the contract for BAM. So they got awarded the Phase A works, which are the below-ground works, but they hadn't at that stage got a commitment to the Phase B works. So those Phase A works were going to take 15 months to complete. So within our programme that we laid out in the tender documents is, while you're completing the Phase A works on the ground, there's a period of time of approximately a year to conclude the second stage, which is the Phase B works. That then concludes. So that timeline was all set out in the contract, and we didn't pay any additional costs in relation to programme and timelines.
Right. Okay. Was it? Are there international norms set down? I know that there are, and you've referred to yourself in relation to the cost per square metre of a hospital of a certain standard, and there are certain standards, grades or levels of hospital, be it a basic one or an elevated one or a high class one, which is what we're talking about here. To what extent did you examine and were the tenders examined with that in view, in order to ensure that the price was kept to the international norms?
I think that's in relation to, we carry out the benchmarking study. So ACOM were appointed to carry out a benchmarking study, and they accessed projects around the world, again trying to find projects of a similar level of care, of scale and complexity in children's hospital projects. So they then produced a report.
They did that themselves?
They did that themselves.
Did you, the management team, do any of that?
Well, we would have had our own consultants did benchmarking reports previously, but we wanted to get an independent benchmarking report done. So ACOM were appointed to do that, and those we were discussing earlier this morning that the benchmarking study concluded that on average, based on the hospitals they examined around the world, the average construction cost was €5,951 a square metre. One of the projects was 8,000 a square metre, one of the projects was 7,000 a square metre, and our benchmarking cost for our project is €6,500 a square metre.
Right. So the last question, Chairman, is this: have you also done an evaluation of inflation costs in construction, in building works, in electrical installations generally, both here and across the globe? And incidentally, in the UK, we had a number of cases, one particular case where a UK contractor was operating here, much to the grief of the Department of Education. So I wouldn't necessarily regard the UK one as the most competitive or the best or the most well-founded in terms of a bid or contract. And I presume you are conscious of that anyway.
Yeah, one of the things we were particularly conscious on and the impact potentially of inflation is that, as been seen by the collapse of Carillion here in Ireland, which has had knock-on implications for other contractors, Salmon, MDY, who are building primary care centres. So if a contractor was in any way to fail during the construction project, that would have a major impact. It's been reported across the water there that Carillion, who are building the Midlands Hospital in the UK, and that because they went bust in the middle of that project is now going to overrun by €300 million, they're estimating, and be delayed by a further 3 years. So the construction inflation, and I think people don't fully understand that consumer price inflation is very different than construction tender inflation. So the Society of Chartered Surveyors in Ireland, on their website, they publish construction tender inflation on a half-yearly and on a yearly basis. And if you go back to, and people say costs don't always come down, well, they do come down at times. So back in 2007, when the construction industry was running full steam ahead, the fallen tenders, and I'm talking about tenders now in terms of receipt of tenders is what they're talking about, from there to 2010, they dropped by 50%. So if you were buying a project in 2007 at 100 million, in 2010, contractors were now pricing it at 50 million. So, which is a huge drop, and people were at that stage were trying to buy business, protect their organisations, use their balance sheet to trade, also looking to get into an adversarial claims approach to projects. And construction inflation from about 2013 started to rise at 3%, and it's been trending now nationally across the country about 7%, and in Dublin it will be trending higher than that. So our construction contractors, they priced the job in 2016, so they've been absorbing that risk to date on the project.
So we're just going to go into our second round of speakers now, and before I bring in Deputy Donnelly, could I just ask, does the contractor bear any responsibility for the financial overrun? In other words, are there any penalty clauses built into the contract, and have any of those been triggered by them not reaching targets?
Their real risk, Chairman, kicks in now in terms of that they now assume the full risk in terms of cost and programme certainty.
But not up to now?
No, sorry, in relation to the Phase A works, yes, they have, because the Phase A works, which is the basement works, that element of it was done where the contractor had risk, and that is actually will be complete in the next few months on budget. So that part of the job has gone well, and again, you might argue that it's relatively straightforward. It's digging a large hole in the ground and creating a concrete box inside of it. But it's into the next phase we are now in terms of the risk, and it is, given the size and the complexity of the job, it is a very substantial risk that they have undertaken over the next 4 years.
And given the transition from Phase 1 to Phase 2, would it not be pretty obvious that the person who's got the Phase 1 contract is going to get the Phase 2 contract, because the penalty for you as the developer is you're going to incur costs of an additional 300 million if you change horses midstream, or you'll have a delay in the delivery date by 2 years. So it would be pretty obvious to BAM that there was no possibility that they weren't going to get stage 2.
Well, you could assume that, but we had an opt-out clause for no reason. So
but your opt-out clause carried 2 serious problems. One, 300 extra million, and 2, a 2-year delay.
But depending on how a cycle goes, so I mean, part of the cycle that we're in here is it's so inflationary, and that a 2-year delay carries a tag, as John says, of 6 or 7% per annum of an uplift, and in a way, if you were in a different cycle, then, and quite honestly, if you were in a different cycle and we were into a cycle of deflation like it was post 2007, we quite likely could have made a very different decision. So, like, at the end of the day, as I said to Deputy O'Reilly earlier on, is the analysis that went in prior to making the recommendation to go ahead factored all that in. So while you could assume that there is actually that opt-out clause, which in essence, if the contractor, and contractors don't always behave well, so if the contractor took a really aggressive approach towards us, and that you found out over the period of working together with the design team, is that really there wasn't any collaboration, because that's what our contract is based on, that if there wasn't a collaboration, well then the right answer, of course, is not to go ahead. So sometimes it's money, and very often, that's what we're talking about today, it's very important, but in order to achieve project certainty into the future, a hugely important part now is having got to this stage, and it has been tough getting to this stage, but having got to this stage of cost and programme certainty, that now everybody on the team, contractors, clients, even in terms of the requirements from the Children's Hospital Group, that they accept now that we're at the end of the day, that's fully defined, and the design team, that everybody works together, and that they honour, and there's a contractual responsibility in any case, but that people are genuinely working together to make sure that we deliver the hospital and deliver it to a really high quality, and that in the delivery of it, that everybody comes to work and goes home safely in the evening. These are all really important things.
And just finally, will penalties, which are now part of the Phase 2 or Phase B, be sufficient to ensure that costs do not exceed the costs that you now estimate?
No, absolutely. And going back to, say, the discussion with Deputy Durkan earlier on, is that, like, the market it's inflationary. It's also, given the amount of work that's going on, there's pressure on contractors getting tradesmen. So while there is an industry rate out there, at the end of the day, in order to get work done, you have to pay what it costs. So all of that risk now goes on the contractors, and if the electrical contractor, and he's falling behind and he needs to have 450 electricians and apprentices rather than 400, he has to go out, because he actually is at a huge risk of a penalty if he does over.
Just the last question, is VAT 13.5%? Or
yeah.
30, okay.
Yeah.
So all the figures that we've spoken about, 650 million, 983 million, are all exclusive of VAT?
Yeah, but the 1433 includes VAT, so that's why within the 1433 there is, as John said, 180 million of VAT. Yeah.
Thank you. Deputy Donnelly.
Thanks, Chair.
And just to remind members, we have to be out of here by 1:45, so if there's 4 contributors remaining, maybe 15 minutes per contribution.
Sure,
or
no problem. Thanks, Chair.
10 perhaps.
Mr. Costello, you've stated several times that the risk now is on the contractor, because it's essentially a fixed price contract. And I would put it to you that you are missing the point entirely on that. The risk has been fully and wholly costed in and is being borne by the taxpayer. If this were coming in at the average price of a hospital around the world, I'd say fair enough. They're going to build us a hospital, we've agreed a price which is about how much it costs to build hospitals, therefore the risk is now on the contractor. But the reality is this is going to be the most expensive hospital ever built anywhere in the world. Now, for anyone around the country who builds a house or an extension or gets a builder in to do any work, and they say, look, we're going to have a fixed price contract because now the risk is on the contractor. If they've been quoted by the contractor, the highest price anyone has ever been quoted anywhere in the world to do that work, then they are clearly being hoodwinked and taken for fools if they think that any of the risk in any real sense is with the contractor. I just find it extraordinary that you would maintain that we're going to have the most expensive hospital ever built anywhere on earth, and aren't we very clever because the risk of the construction cost of that is with the contractor. I find that extraordinary. I wonder, would you release to the committee the various reports? Because I will be very surprised if several of the figures we're discussing here are like-for-like comparisons. For example, your initial estimate was based on ACOM saying in 2014 that it cost €2,500 per square foot or per square metre. Now, it's 160,000 square metre build, which would give you a total construction cost of €400 million. Now, I was on the Finance Committee when the lotto was sold for €400 million, and the conversation we had was that that €400 million would pay for the National Children's Hospital because that was the estimate of how much it was going to cost. So that's where it all started, at €400 million. And if ACOM are saying, back in 2014, €2,500 per square foot, 160,000 square feet, that's 400. You go on to say, yeah, but they factored in inflation. And they did. And if you factor in inflation at their 3%, you move from 400 million to 460 million euro. So ACOM's estimate of the price it costs to build these things would have given us a total build cost of 460 million in 2018. And yet you say they gave you another report in 2018 that said, in fact, it's not 2,800 per square metre, it's 6,000 per square metre. So somehow, in a very small period of 4 years, the estimate from ACOM on how much it costs per square metre, somehow it jumped from 2,800 to 6,000 per square metre. I don't believe that. I fundamentally do not accept that they are like-for-like comparisons, because the materials being used on a project of this size, they're not all being sourced in Ireland. The labour isn't all being sourced in Ireland. The professional services aren't all being sourced in Ireland. These are international commodities. And there is no way that bricks and mortar and the amount of money that you pay to sparkies and chippies and engineers doubled in that 4-year period. I just don't accept it. We have a second report you have conveniently from Linesight, which says there's been a 95% tender price inflation, which fits quite neatly with the massive overruns we're discussing today. There have also been 2 international benchmarking studies are referenced, one of which I presume is Linesight. Can you release to the committee the ACOM work that started with 400 million, or the 2,500 per square foot? That's the 2014 one. The 2018 one that somehow goes from 2,500 per square foot to 6,000 per square foot. And the Linesight report, which estimates a 95% tender price inflation. Can you release those reports?
Sure we can. It's all documentation that was submitted to the department. And just to go up and say, our board was appointed in August 2013. So we were asked to prepare a preliminary budget late 2013 into 2014, and that's the first one we referred to that used the rate per square metre by ACOM of 2,500 a square metre. So that in total project cost, that came in at 800 million. So just so that we're calling like for like, because when you start talking about applying rates to areas, you have to bear in mind that as well as we're talking then about VAT on top of that, and then the additional costs that John went through earlier on for the satellite centres, and then all the additional costs of design fees and all that. So it's important that say and you came up with a figure there of 460 of the 800. So it's the 800 was the starting point there.
Okay, thank you.
In relation to risk, and I mentioned it in the statement earlier on, is one of the failures, or there were two major failures identified for major complex projects, is that there's no collaboration between the different parties, and it's all based on a conflict basis, that the contractor bids the job potentially below cost. Because if you look at the profits, the turnover and profits of the top 10 UK contractors, is 5 of them in last year were loss-making, and this is a boom time. So it's an aggressive business. So what happens is, a lot of the time is, as John says, it's a big attractive contract, and contractors, they're well skilled, and they would feel if you go into a contract where it's you inherit a design, that you'll have loopholes. That
I understand.
Yeah, but that's the thing.
Well,
about,
to that point,
yes.
No, and in fairness, you've laid that out. Okay. To that point, then, the profit margin that the main contractor will make. The initial bid was 687 million. That will have had a profit margin, or an internal rate of return, or a return on invested capital, or whatever metric they want to use. There will be the net present value to that contract. Given that there's an additional 450 million and more now since then, or nearly $1 billion more since then, has their margin and/or total profit increased substantially, or potentially decreased substantially?
So the process, again, of the two stages, the rates that they bid at 2016 are the same rates as that are applied now to the updated quantities based on the revise. So there is no reason. I mean, they may be reduced because of the pressures in the marketplace, but the mechanism is very clear that there isn't actually an opportunity to increase margin.
So the margin hasn't gone up?
I mean, it's not visible.
Yeah.
We don't have visibility into their accounts. But
you don't do open book with them on a bill of quantities?
No. It's open book in terms of the rates, but that not on profit margin.
Okay.
Yeah.
I'd like to come back to the main figures, because there's a lot of different numbers being thrown around here. And if you would, Chair, I wonder if we could get from the board a like-for-like comparison, because there's lots of different figures, some of which include VAT, some of which don't include VAT.
Yeah.
Now, as I see it, there are 4 big chunks of cost. There's Phase A, which was the below-ground work. Get the site ready. And in that, I would be including decanting buildings, whatever it is, get the site ready and put in the foundations. There's Phase B, which was build the building. There's a third piece, which is around the commissioning, the IT, and all of that. And then there's a fourth piece, which is tax. And tax isn't terribly relevant, because tax is what it is, and it's a percentage to what happens, right? Now, the 1.73 billion euro, am I right in thinking that includes all construction works on the St James's site, Tala, Connolly, commissioning of all the sites, IT for all the sites, all equipment for all the sites, all training required? Is that everything? Or could we potentially be meeting up here in a year or two's time and you say, well, it didn't include the extra 50 million for IT, and it didn't include the extra 50 million we needed to choopy the employees across? Or is that every conceivable cost associated with opening the doors of this hospital? Okay,
so I'll speak to the part that John and I in the National Paediatric Hospital Development Board are responsible for, which is the 1.433, right? And yes, in the process we've gone through, we have cost and programme certainty. The additional that brings it up to the 1.73, if Eilish, do you want to just speak to that?
Yeah, Ms. Hardiman, I'd love to, and I would like to come to you in one sec, but do you mind if we just do the 1.43 and then come over, if that's okay?
Yeah.
So the 1.43, does it include commissioning?
Absolutely, yes.
And does it include IT?
Include your ticket.
Yeah. So it includes building commissioning, so in terms of turning on the air handling units, commissioning the IT system, but it doesn't include clinical commissioning, because clinical commissioning is not part of our remit. Our remit is to design, to build and equip the hospital. When it's completed, we will hand it over to our client, but then there is a clinical commissioning to take place.
So where does IT fit? Clinical or non-clinical? Is that in your 1.4 billion?
ICT, in terms of what we call the behind-the-walls piece, so literally the cables, the data points, providing the rooms, that sits with us.
Okay.
But the in front of walls piece, in terms of the software systems to run the and the actual server rooms, we'll fit them out. But that doesn't come within our remit.
So
That,
when
again,
you
is part of
leave,
our plans.
I know there's overlap, I'm simplifying, but when you leave, when you finish, there is a building, it's painted, it's finished, it has all the cables, it has all the oxygen pipes, it has all of that, but there's no beds, there's no equipment. There are beds?
There are beds. No, again, our remit is to design it, to build it and to equip it. So we fully equip the hospital. So, for instance, putting in the imaging equipment, X-rays, CT scanners, putting in the beds, the lockers, the medical devices, all of that is part of our remit.
It is.
Correct, and that's within the 1.43.
So in terms of the physical structure, right, let's simplify again. There's a day that the doors open and the clinicians and the patients walk in, right? In terms of what they will see and use in the hospital, is the only thing missing at that point ICT? Because it sounds like the beds are there, the diagnostics are there, the canteens are in place, the cookers are there, that's all there. Yeah?
Correct.
The syringes are there.
No. In terms of
medical equipment,
So
disposables.
consumables would not be part
Consumables
of
are
it.
not there.
Yeah.
Okay. So for your 1.433 billion, would you mind urgently, if you can, because we have the officials here, I think, Chair, next week, would you be able to please give us an evolution of that figure? Because we're comparing different figures. The 1.43 billion has VAT in it. The 687 million from BAM, that didn't include everything we've just talked about. It was a bit of what we've just talked about.
Doesn't include equipment.
Doesn't include equipment. Okay. So we know that the construction costs have increased by about 320 million, and then an additional 130 million on VAT, Tala and Connolly, site supervision and design, professional fees. Okay.
And we did a review of the cost of equipment as well, so there's actually...
Okay. Site supervision and design fees, to me, they're construction costs. They're part of building your building. If your professional fees for building your building go up, that's a construction cost, right? But let's take VAT out. The construction costs have gone up by about 420, 430 million, excluding VAT. Would you mind working backwards? You may not be able to do it now, that 1.4 billion, because we're tracking different numbers. You started the 687 million from BAM. That then jumped, by the time the final capital cost was identified, that had gone up by 346 million. We were nearly at $1 billion. So from BAM's original bid, it then jumped from about 637 million to nearly $1 billion, right?
To 890.
Yes,
Yeah.
I think some of this information is in the slide deck. So our first business case, preliminary business case, was done in early 2014. And at that stage, we quantified the project as costing 800 million.
And Mr. Pollack, does that include everything that is included in the 1.43?
Correct. Yeah.
Okay. So the jump in like-for-like comparisons is 800 million in 2014, is that right?
Correct.
Up to 1.43 billion.
Yeah, but there was an intermediary step after the receipt of tenders in 2016. So when our business case was submitted to government in early 2017, it was now 983 million.
Okay, that's part of the process, but just in terms of starting point, end point.
Yeah. But
It
there
went
was
from 800 million,
8 to 983 to 1.4.
you're right, so about 800
And that's not like
to
for like
1,400.
basis, yeah.
So it's a 633 million increase from 800 million, essentially. Yeah, right. Thank you. Now, would you mind, and maybe the table is there, but it'd be very useful to have that walk, but on a like-for-like comparison, right? Because to go from 800 million to 1,400 million is quite the jump. How much of that is genuinely inflation? How much of that is additional unanticipated fees? How much of that is the underestimate of the quantities of materials that you were going to use? I think that would be very useful.
Thank you, Deputy Donnelly. Can I move on to Deputy O'Reilly? Or?
Oh, beg your pardon, Chair. Yeah, can I just a very quick question as well then from Ms. Hardyman. We may not have time to answer it now, but your budget of approximately 300 million, I presume, is that about right?
I think just to your so the building and the equipment is with the development board. Anything that's outside of the walls from an ICT perspective is yes with the Children's Health Ireland, and and is the operational costs, the future operational costs, and those obviously are staff, usually pay and non-pay. So from just from an ICT perspective.
Sorry, just if I could just step back one more, and apologies, Chair, I know I've gone over my time. The 300, the gap between the 1.43 is all with you, is that right?
Yes, but one part of it is delivered through the HSE because it's the National Electronic Healthcare Record. Right. So the ICT contains two elements. You're right, it's these and everything outside of the wall that we need for the hospital, and that's in is one of the increases. And then the HSE have to implement the National Electronic Healthcare Record is another cost that has been quantified here. And we have to get ready to move into this building. So when it's handed over to us, we have to service commission it, train all the staff and do all the moving of patients into it, and that is in our projected
Just quickly, how much of the 300 million is ICT between you and the HSE?
About 150 million given a figure around it, and that's broken down, as I said, to the hardware that we need and also the electronic healthcare record.
And software.
And software, and the people to help implement those changes.
And final question, thank you, Chair. On your, because we've spent an awful lot of time talking about the increase from 800 million to 1.4 billion. Your 300 million, what did that start at? Did it start at 300 million or less?
Less, but where the changes that has happened since
sorry, just how much less? What was the equivalent to your 800 million?
The ICT is increased by 9 million. And the reason for that is in the original proposal that we put in 14, the functionality to do the interfacing between medical devices and the electronic healthcare record was supposed to be in the electronic healthcare record bid, but the advice from the HSE when they went to proceed put that through was, no, you need to put that back into your
So your 300 million back in 2014 would have been 291 million.
Yes, so that's the only difference in the ICT for us is 9
And can you provide us with some, I'll finish this, Chair, can you provide the committee with some documentation?
Absolutely.
Because it sounds like your budget hasn't really moved much at all.
No, we haven't moved too much, and I think what we have done and demonstrated, again to be open and with the committee, is what has changed for us is our projected operational costs, and that's purely because of restoration of pay, because we were asked to demonstrate, we haven't changed our head counts projections, but obviously the pay has gone up with restoration of pay.
But to be clear, you would stand over that in 2014,
correct,
your estimated budget was about 290,
correct,
and it's gone up to 300.
Correct.
Okay, thank you. Thank you, Chair.
Thank you, Deputy Donnelly. Now, Deputy O'Reilly.
Thanks very much, Chair. I have a couple of questions, and maybe some detail might be needed after this meeting, but in advance of next week's meeting, so we'll just go through them. So in August, when as I think it was August, you said, where you started to realise where you were given some consideration to perhaps not continuing with the project, and you were meeting on a weekly basis as a board. How was that concern communicated to the Minister? I mean, would you have been at those meetings making sure that the Minister was kept in the loop, that the Minister was kept informed, and that the concerns that you had were shared with the the most senior person within the health arena. So perhaps you could outline for me, and without necessarily just a description of the structure. I think we all understand that. But if you were satisfied that the concerns that you had with regard to the cost overruns had been fully made known to the Minister, and that he would have been fully across it back in August, and as you say, with those meeting on a weekly basis, I'm sure that would have caused some concern. A number of the questions I was going to ask have been asked and covered already, so I'll stick to the ones that haven't. With regard to the proposed Children's Research and Innovation Centre, can you tell me who owns the land that it's being built on? Who will own the building? And how will the construction be paid for? So if it's to be paid for through some sort of philanthropic fund, or how is it envisaged that will be paid for? And I think that brings me on to my next question, which is one around the name. And there was some concern about a memo that went to Cabinet that alluded to the fact that the naming rights might be sold off. And the Minister moved quickly to say he wouldn't sell the naming rights for the hospital, but he didn't say he wouldn't sell the naming rights for individual institutes or small little discrete areas within. So does that form any part of your plans? I mean, for my part and for Sinn Féin's part, notwithstanding the opposition of the other parties in the Dáil, we believe the hospital should be called Kathleen Inn Hospital. It's very, very simple. We think there's good reasons for that. But notwithstanding that, is it intended to do, as they do, I see, in many of our universities, to sell off the naming rights for a particular institute or a particular area of research or whatever? And is that the intention? And if it is, have any discussions taken place in that regard to date? Is there any figures, any ballpark figures with regard to investment that you might be able to share with us? And then, with regard to the Crumlin Children's Hospital, what are the plans now for Crumlin Children's Hospital? What do you know what's going to go onto that site? Will it still be available to you? How is that going to work? And just to return to an issue that I raised earlier with regard to the additionality of beds, will beds in the community, beds in other hospitals that exist already, not necessarily even in the 3 specific children's hospitals, will there be beds closed in those areas? Do you envisage, will there be bed closures? For example, will you be saying to people in Limerick, well, look, you don't need that bed because there will be a bed? Because obviously that's going to have an impact on the sum total of beds that are available for children. And yes, you say in your opening statement that there are lessons to be learned in relation to the wisdom of pursuing cost reductions on competitive tenders and ensuring the sufficiency of tender information. So you might just outline for us what those particular lessons are. I mean, that might be something more appropriate to a more detailed follow-up correspondence. And if you have made known the lessons, and the very expensive lessons, can I point out? I mean, I note the word disappointment. I mean, I might use a stronger word than that, but the lessons that you're learning are extremely expensive lessons, Mr. Costello, very, very expensive lessons. But have you communicated the lessons that you have learned to the Department of Health? And if you have, perhaps you might be in a position to share that correspondence with us. Thank you, Chair. Thank you,
Deputy O'Reilly.
Thanks, Deputy. If I ask Eilish, there are probably 4 there around the crick, the naming, Crumlin Children's Hospital and the additionality of beds. So if you
want me to take those first?
Please, yeah.
Okay. Thank you, Deputy O'Reilly, and I do think it's important that you do make reference to the broader health system, because the planning for this hospital has been very much from the get-go been done as a whole island approach to it. So there's a national model of care for paediatrics that underpins the policy position as to why we need to consolidate the high-end tertiary quaternary requirements into one hospital, and that for that to actually based in Dublin. But we have, through the HSE, been working with our colleagues across the system to ensure ensure that we are planning in a collaborative way around children's health. So we have an integrated care programme for children, which we engage with. So it's not just with our colleagues, as we say, in Cork, Limerick and Galway in the acute system. We're actually dealing with our colleagues in social care and community and mental health, which is really important, obviously, in the experiences that first world countries have with young people and mental health issues. So we have identified that there are services that could and should be done locally in the regional units. So there is the model of care maps out the services that can be done in regional units and the services that can be done in local units and the required resourcing of them. We actually have appointed a paediatric network lead, which is a surgeon, to work with those regional units on the appropriate utilising of their beds. This is about transforming the children's health care, and the biggest transformation is around the ambulatory services. So what we're putting out at Donnelly and Tala is testing within the Irish system the feasibility of safely actually delivering outpatients, trauma, orthopaedics and urgent care in a very efficient manner. And we would envision that in testing it in these units, it is something that the wider system could then actually look at what their bed utilisation. But to be quite honest, there is repatriation needed from the Dublin hospitals to those regional units, but only in a supported way. And we work very closely now with this clinician in place, trying to ensure that we put the education and the supports in the regional units. Increasingly, we're actually holding shared clinics down in the regional units, so that we're trying to keep it child and family centric, whereby if they come in for their service, they can and should have them locally, only needing to come to Dublin as required. So that model of care. So there is no, we see additionality. Cork certainly has plans for a hospital, and in the plans for the elective hospitals, we have actually been working with our colleagues in the regional units, identifying, the parameters that we use for the model of care to try and ensure the most efficient use of bed planning. But Cork is the only one that has identified additional plans, and have plans actually to develop that.
Additional beds in, but my question was about any plans that might exist to close beds that are out there at the present time currently being utilised for paediatrics.
No, but the point is, I do think we are testing the model of care with the ambulatory and urgent care centres that could possibly bring benefits around that, but that would need to be tested and demonstrated and then taken into consideration as part of the transformation programme. Moving up, if I may, then to Crumlin. And so just for, I'm sure, and I know the committee, and I think it's important to record it, because the last time we were here was with your support about trying to get our legislation through to merge the 3 children's hospitals, and thank you for all of their members for their support in facilitating that to go through in 2018. So as from the 1st of January, the Children's Health Ireland is governs and provides for paediatric services in the Dublin, in the area, in the locations of Crumlin, Temple Street and Tala, and will be opening up services in Connolly in the middle of this year. As part of that, the voluntary boards, which is of Crumlin and Temple Street, had to voluntarily transfer their assets and liabilities to the new entity under that legislation. The Crumlin Hospital campus was owned by the board, and that has transferred to Children's Health Ireland. On the condition, and we can only use our assets to actually deliver services to children. So the use of the future campus has not been explored. Well, we're going to be using it, to be quite honest, delivering children's health system until we open the new children's hospital. So it's occupied for the next 4 years. But we are going to have to engage in a planning process as what could the future use of that be. Now that we've started and have the merger has actually happened, we see that as something, as a planning option that we're going to put into place over the next few years, but we certainly have use for it for the next 4. But its benefits has to benefit Children's Hospital. That was the condition under which it was transferred, and under what is the only way that we can actually use it. In relation to naming, then you are right in the Minister, and it is important, I think, to have it clarified that there is no proposal to sell the name of the Children's Hospital, and the Minister actually has confirmed that. We have actually already reported that there is a process that we are going to in relation to naming the hospital. That is going to acknowledge the work that has been done to date and take into consideration nominations and submissions that have been made by others, and we intend to kick that process off now to actually come up with the name. In relation to, is there an opportunity then for under philanthropy and fundraising for philanthropy to parts of the hospitals to be recognised? Yes, that is something that is there for consideration. Many of the children's hospitals actually have that, and specifically in relation to the Children's Research and Innovation Centre. So while the planning permission has been secured for that, and if I'm right, John, those lands were owned by HSE, so, and this means that they remain within HSE, whatever's built on there. But the funding for the Children's Research and Innovation Centre will come from fundraising, philanthropic fundraising, as it is in the existing hospital in Crumlin. That's how it's actually funded. So we see that as an ideal opportunity for naming one part of actually the building. In relation to other, and there are commercial elements whereby that are feasible that we are exploring, but these are only in discussion stages and will be very much working through HSE and the department.
I found that, and I saw in, I think it was a post on social media where somebody who was fairly outraged at that suggestion that the naming rights for any part of the Children's Hospital would be sold off. And they said, tongue-in-cheek, I'm sure, but could we see the, you know, they named a brand of cigarettes, Children's Cancer Research Centre. Now, the fact is, once you start that process, you get less and less control over it. And I mean, I could point to examples within the third level sector where not only does it not represent poor value for money, but it assists individuals in purchasing a certain amount of credibility that they possibly shouldn't have by virtue of the fact that very wealthy individuals you know, in a very tax-efficient manner, channel money into certain causes. It would concern me. It is something that I don't think, and you can say it's done all over the world, but sure, I mean, we only have to look across the water to see what they're doing over there. We're not replicating it, and just because they're doing it somewhere else doesn't mean that we should be doing it either. That would concern me. So do you have, at this stage, given that the process appears to be advanced, do you have a set of criteria so that we couldn't have, for example, the cigarette brand Children's Cancer Research Centre, or indeed the fast food brand Obesity Centre? Have you got criteria in place, and how are they drawn up, and how will they be enforced?
We are, as again, kicking off the process now about that, and it will have criteria, and we will share those with you.
Thank you very much. Ms. Hardiman, can I...
A question to Mr. Costello.
There are two more there, so I'll deal quickly, and perhaps it's something we can come back. So, I mean, obviously as part of the exercise we've done, and ultimately the report to the HSE, we have learned lessons, and there were positives as well as negatives, as always, but we identified two in my statement there, and in relation to, just to take through them a little bit more, on cost reductions, because we're in an inflationary cycle, when we got the tenders in, the tenders were higher than the pre-tender estimates, and invariably in those cases people do look for cost reductions. Again, in hindsight, you know, looking for a cost reduction at a time when prices are still inflating at 6 or 7%, and say a cost reduction might be an alternative material, but while you're in that inflationary cycle, there's no guarantee that the cost reduction will come to, and eventually you'll end up going back to where you started. So that was a lesson learned in the cycle, and you don't necessarily, you cannot predict those things. They were all done. You know, well-intentioned, and they were deliverable, and the contractors have bought into it. But when they over a period of months, then when you try to interrogate their deliverability, it wasn't possible. The other one then was in relation to the reporting. So just get John, just in terms of we were meeting regularly.
So the reporting structure. So we would have reported to the CHP&P steering group in August, and we did, at that stage, given the quantity of the cost escalation of 200 million, we said at that stage we would look at alternative options that could be pursued. And that's what we spent the next number of months completing the two-stage process, looking at the alternatives. So they both came then at the end of October at the same point to say this is the final price, but notwithstanding that, this is still the best option to proceed with the project.
Thank you very much. So we have roughly half an hour left. So we have three other contributors. So we're going to take Deputy Kelly, Deputy O'Connell and Senator Burke.
Are you sure?
Yeah, I'm just getting my bearings.
Oh, that's being precise. Okay, thanks very much. I thought Deputy O'Connell would be first. Earlier on I asked you obviously for full documentation in relation to the decisions that were made that would include minutes in relation to key critical milestones as regards to escalation of the project. Can I also ask you for a full list of attendances of who was at the meetings and also the subcommittee meetings for the duration of your existence, please? Second question, I want to go back to John, what you said, Mr. Pollock. So, what date, just for clarity again, because I want to run through this in my head based on other evidence and information provided to me. The 983, what date were you aware that the project was going to cost that?
Those figures were included in our definitive business case of February 2017.
February 2017. So, the 60 million increase, what date was that?
September, we had quantified it, but it hadn't all, so some of it was still early warnings in relation to particularly the sprinklers, because on board Penola hadn't adjudicated on that.
September 2017.
So September 17, we said there's a risk here of 60 million.
Okay, and then in August 2018, as you said in evidence previously, August 2018, it was 140 million more.
Correct. And that's in relation to the construction costs.
So that August 2018, so that would have been communicated up through Mr. Sullivan and up to Mr. Breslin, I presume.
That was our reporting structure, correct.
Okay, so we can assume, well, it's not assume, but it's a fact, that Mr. Sullivan, who is in that role for a reason, and Mr. Breslin, who obviously talks to the Minister every day, in August 2017, that would have been communicated up the line. Is that correct?
Well, we report to the
But
chairs.
it would kind of be strange if it wasn't.
I say we report directly to the chair of.
But you definitely, Mr. Sullivan knew.
Yeah.
So Mr. Sullivan knew, but we can't guarantee that Mr. Breslin knew.
We briefed the department in August 2018.
As well.
Shortly after, about a week after we briefed.
What date was that?
I'd have to check our
Can you come back to us
records,
with
but
that
it was
date?
sometime around the middle of
There's
August.
a reason I'm asking this question.
Yeah.
Obviously. So, in August, so the total figure then, what would have been the total cost of the project then at that point, in August 2018?
We didn't report on the total cost. We reported on where the two-stage procurement process was, and that overall we were looking at a cost escalation of 200 million.
So, but would have assumed that it was 983 plus 200?
Well, there are certainly other elements that would have been, so like that isn't included in that. The issues related to the urgent care centres that I referenced, that two of our contractors had got into financial difficulties prior to signing of contracts, so they wouldn't have been part of that update. We were updating on the construction costs for the main children's hospital on the James's campus.
Okay. So, in August 2018, it was 283 plus 200 plus VAT plus urgent care centres plus issues with contractors equals X. That was the equation.
We, I say, purely reported on the 200 million.
But am I wrong in what I just said?
Well, I don't know what in terms, so I say report in
I just repeated back what you just said there. That's all I did there.
In September, we identified the 60 million, and then in August, we identified the 200 million.
Okay. Let me repeat, because there's a deep concern here. The 200 million was made up of what?
The 200 million was related to the Phase B construction costs.
Why was there an escalation of 140 million? I got the 60 million, you explained that, the whole issue in relation...
For a lot of the issues, so obviously the on board Panola issue it now...
I know about the 60 million, you've explained that well in fairness
so
to you. The 140 million.
The completion of the user engagement at that stage...
So user engagement was basically the other three hospitals?
The user engagement, well, it's done for the one hospital, yes, but obviously the user engagement groups had concluded their work at that stage.
So the 140, so the 60 million was the whole issue with the Lower Canal in September 2017. The 140 million was the user engagement.
It's more than user engagement. The 7 categories are set out in the table there.
Okay, fine. Yeah, I understand, right?
Yeah.
Just remember there's thousands of people watching this. Okay, so that's 283 million plus 60 million plus 140 million. 60 million for what you've outlined, the whole issue. And then there was the 140 million, so that's 200 million. And you reported on that 200 million in August, up the line to Mr. Sullivan, and then a week later you reported it to the department.
Correct.
Right?
The 200 million figure.
200
correct.
million figure.
Yeah.
In reality it was 283 plus 200, which is made of 60 plus 140. And in fairness to you, just to be complete, you're saying, but that didn't include VAT. Didn't include issues in relation to urgent care centres, and it didn't include issues in relation to 2 contractors who had problems. For completeness, you're saying that. Is that correct?
Yeah, so again, definitely so totally clear. So in September 2017, we identified the 60 million, and that included an issue around 2 contractors getting into financial difficulty on the urgent care centres.
Okay. So the urgent care centres and the contracts is all one issue?
Well, but they're 2 separate contracts.
Okay, fine.
So the
get that?
Yeah.
Good clarity, fine.
Yeah.
So now it's the 283 plus 60 plus 140, which is 200 plus VAT, plus the 2 issues relating to the urgent care centre and contractors. Okay, got it. That's August.
Sorry, just to come in there, John. I mean, obviously at the same time we were doing an analysis of the equipment, so that hadn't fed into the information that Deputy is talking about there.
Important clarity.
No, it is, yeah, because I think, and I'll let you back to John in a second, because he's in full flight there, but
he is very helpful.
Yeah, no, just that the reporting that we did at the time was an update on the development of the Stage 2 process, and it was an update to say at this point in time, in relation to the construction cost, which is, it's now the construction cost now is 980 million, excluding VAT. So it's within that bucket of costs as opposed to the overall development costs.
I'll return to this. I'll return to this in a different form, but that's not what was communicated publicly at the time. Let me just say that. I have a number of questions, so that's why I wanted that broken down, because the figures which were communicated to the department in August 2018 are critically important. Okay, a few quick questions, because some of these are costs, so based on operations, so I presume it'll be Ms. Hardiman will be answering. Oh, sorry, just on the 1433 up to the 1.7. The 1.7, the 1.4, in fairness to Deputy Donnelly, you've outlined the breakdown. Is there any ancillary costs that any surprises outside of that in relation to reinstatement costs or disturbance costs in relation to the project that aren't included in those figures?
How do you mean reinstatement costs?
Any costs, anything in relation to any of the buildings nearby, disturbance for the work, any other costs on top of the 1.7? Because you said absolutely earlier on that that was the figure, 1.43, and then in fairness, you've explained, Ms. Hardiman explained, and in fairness, there's only 9 million of a difference. So that's absolute, so.
Sorry, just so, 'cause again, in the slide deck, which the Deputy has...
I know, but the people at home don't have this. So.
No, but I'm going to elaborate on it, Deputy. So, not part of our project is the family accommodation unit. So, we got planning permission on that because it was important to master plan the site. The Children's Research and Innovation Centre is not part of our projects. That's not part of the contract
no problem
that we've let to BAM. The changes in clinical standards and practice, and they evolve, so the scope is as it is at present, but if clinical standards and practice change, and if that changed the scope of the project, that would impact on the costs. Construction tender inflation in excess of 4% post-July of this year, 2019, that's under the contract not provided for. Changes in legislation such as VAT, PRSI, labour rates.
Okay, can you answer my question relating to reinstatement or disturbance? Is there any costs?
I don't understand your question, sorry.
So is there are there any costs relating to the site and disturbance on the site, reinstatement of other buildings, any ancillary costs relating to any of that?
Well, there is a legal action on the O'Reilly. I'm not sure.
I mean, that's not something that you have control over, to be fair to you, but is there any other anticipated costs? That's all. If it's no, it's no.
There's no reinstatement.
Okay,
costs,
fine.
Yeah.
Can I ask, from an operational point of view, will this hospital operate in A&E 24/7?
Correct. This is the emergency department is,
fine.
yep,
That's
absolutely.
Grand. The operating theatres, how many of them are there?
There are 22, and that includes a cath lab.
Okay, and will they operate 5, 6 or 7 days?
Some of them, 2 of them are urgent emergency, and they will operate 24 hours required, depending on needs. The rest have actually been programmed to work up to, some of them to 6 for safety reasons, because they're, the surgery that they're undertaking is highly complex, so we do not like undertaking very complex surgery, finishing at 8 or 9 o'clock at night, going into critical
Makes
care.
sense, yeah.
So we have, as part of the planning for the theatres and the requirements, we've benchmarked what are the opening and operating hours of those theatres. Yeah.
Okay, the McKinsey report, granted a long time ago, well, 13 years ago now.
2006.
Yeah, 380. We now have 473. I know. If you look across the sea, the NHS report in relation to the use of technology, you're never going to get anybody inside here who's a bigger fan of e-health, by the way. I say this consistently inside here. When it comes to sláinte care, it was one of the things I concentrated an awful lot on, is to do with my background in technology. But in relation to technology, the decreases in relation to clinical attendance as a result of the advances in technology, dare I say it, particularly when it comes to, children. You see the report, it's only out a couple of weeks ago. Now, surely that will have an impact after we do the figures which I asked in the last round of questions in relation to bed usage. So, I'm concerned in relation to the use of technology, the figures which I asked about earlier on, the escalation, and has all of that, how do we know that that's all accurate? How do we know we've spec'd this out correctly?
So as part of planning for the capacity requirements, we did take into account the model of care and technology and how it can help. So we are, and I'm glad to report, we are actually implementing some of those changes at the moment, whereby we are running virtual clinics, and we are without the patient seeing face-to-face contact with the clinician, but with the clinicians actually communicating to them either by phone or actually some of them by Skype. And we are also running trauma access clinics, for example, whereby they're just looking at all of the digital presentations and not having to bring the patient in, but communicate them. So we are demonstrating that, and part of our planning, we did put in a percentage of where we expected that technology to be. Now, where it will, though, increase in us is our clinicians will still need to be in a room, communicating possibly with patients at home or with the clinicians in Cork or Limerick. So we have actually identified that they still need to be somewhere in a space. I think the most important is that and you're right, we still have 380 beds in this hospital as projected at the time. So it's important that one of the things that definitely has deteriorated is our ability to meet our clinical demand.
One last thing, Mr. Costello. You know, obviously this has been probably at times a difficult responsibility. I have to say, in the last 6 months, I have no doubt, given the it's the typical interview question. I'm sure you've interviewed many people. If you'd your time again, is there anything you'd do differently?
I think that the lessons learned is an open response in terms of what we've learned from the whole exercise. I said in the statement is, in terms of the procurement, that was and still is the best way to procure the job.
So you wouldn't do anything differently?
In fairness, Deputy,
I know, I read it out.
No, in the lessons, but we have also broader lessons learned as well, so it does highlight.
What are those broader lessons?
Well, I'm happy enough to
There's only one. I saw, in fairness, I read out what you said in relation to electrical and tendering and all of that.
Yeah.
But I didn't see any broader lessons that you said.
No, I didn't say, but I said in the documentation and the report we prepared to the HSE, we have been open about.
And you're going to release that report to us?
We can, yeah. What worked well and what didn't work well, because there are positives as well as negatives. The process actually worked well. And we use the term disappointed and very disappointing. What was very disappointing is that at the tender stage, the price that fed in ultimately to the contract award underestimated ultimately what the real cost of doing the job is, because what we're paying for the
classic
project,
though, it's a classic.
Yeah, but
it's a classic. Go down to Cork and look at the convention centre. Look what's gone on there. It's a smaller project, but like. Sorry, just let him finish.
Yeah, no. But at the end of the day, at the end of the day, we're paying the way the price is evaluating. We're paying for what we're buying, so that in terms of the ultimate quantities that have come through from the completed design, we're applying the rates that were bid at 2016 to give us now what we have as the contract. So,
thank you, Mr. Costello.
There you go.
Deputy Kate O'Connell.
Thank you very much, and I suppose to some extent I have to congratulate you on getting to this phase with the hospital, and like many members of the committee, I feel that Irish children have been neglected for a long time with Crumlin, and I have reason to be there a bit myself, and I often send the Minister for Health photographs of the walls, stuff just to remind him what it's like. So I do look forward to this project reaching completion in 2022. Mr. Costello, I'm not a big fan of fellas learning on the job when they're getting paid to do a job. And I think it's quite shocking that you would say that a process has worked well when we are at the price we're at currently. And it is Rule 101 that the difference between the tendering price and the contract price is where you have to watch. So who was watching this? Were there a team of QSs employed at the initial phase, at the tendering phase, and that differential between the tender price and the contract price, can we just assume that, I'm assuming there was a team of QSs involved, and I'm assuming that all of the work that they did was therefore pointless if there was such a difference between point 1 and point 2. So if you could just perhaps elaborate on that. Can somebody clarify, and I know Deputy O'Reilly, Louise O'Reilly, as I was coming in, was talking, I missed the start of what she was saying, that on the site, other than the 3 bits that you identified as being operated by other people, that the land will all be kept under HSE ownership. And can you also please clarify that no external private company will be contracted to provide the services in the hospital? So, for example, that the cath lab wouldn't be run by a private entity, or that the minor injury unit, if there is one, or whatever's in it, that we're not going to carve out bits and give it, although being owned by the HSE, being operated by a private medical company. It's something that we will probably discuss in this term at the Health Committee, but I've seen an emergence of private companies operating in sites with HSE logos over the door, and it's something that concerns me quite much. So if you could just perhaps clarify that for me. Mr. Pollock, you referred to the change in clinical standards, and I'm assuming what you're saying is that between now and 2022, if some piece of equipment or infrastructure comes on board that would be of benefit to the hospital, that obviously you want to move with the times. And is that what you're saying? So technically there could be another bill if a different type of magical cable comes out or something, and you'll have to just do it, I'm assuming. And we can't obviously predict that right now, I'm assuming.
Medical technology is emerging literally on a yearly, 6-monthly cycle. So we want to buy our equipment as late as we can.
Absolutely. To
get the best equipment at that time. But where the world will be in terms of technology in 3 years, we don't know yet.
Absolutely. So that's what you're referring to.
Correct.
There. So perhaps you, Mr. Costa, you could answer the first few questions there when I get the next bit.
Sorry, I just, because the shorter answer, Eilish, is probably the one in relation to the operation of the
So the operating model for the hospital, as it's currently been proposed and as we're trying to staff it and develop it, does not include the outsourcing to private companies of services, as you have outlined, which I am familiar with within the system. Having said that, obviously we will be contracting to, cleaning and catering and other support services as would be expected in the hospitals at the moment. I think it's important to add that this hospital actually has been designed to be flexible over the next 20 years as much as we could project where we think future technology is going. And that's very important because of the investment that actually has been made. So we have contributed to the design and got advice from other colleagues that have built hospitals in how to keep the design as flexible as possible, because we do know that services will develop. We do know that we currently have services that are being provided in the UK and internationally that will be repatriated. We have projected and identified where new service developments, and I'm glad to say we are actually making progress with new service developments that we will be able to accommodate. So while there is a risk around, and I do appreciate new technology, it is moving very fast, it's important to give assurance that the investment here is designed in a way to allow flexibility to accommodate the new model of care going forward.
So the hospital said can evolve as medicine evolves.
Yeah, so we've identified where are the key areas that involves, and it is at the high-end critical care, and we have an ability to actually, again, increase the critical care unit within the hospital, and the other area is obviously ambulatory and outpatient. That's where the biggest changes, and we have built in that flexibility into the hospital to accommodate that future projection healthcare trends.
Sorry, Senator, did you want to...
No, just you might want to finish off with Deputy O'Connell first.
Yes, sir. Sorry, Deputy. Just coming back to your first question there, and I'll just very quickly run through what I said in the statement is that from when we were appointed as a board, the board is based on appointing people with the skills and competencies to deliver a project of this size and complexity. So the skills of project management, construction, procurement, architecture, engineering and legal, all those skills were in. And then we went to our vision, we employed a really capable and experienced executive team, and then having the people to deliver, to actually deliver on what we were remitted to do, which is design, build and equip the hospital. And going through then the stages of employing the design team. But fundamental to it all was that there was a clear process as how we're going to do different stages, whether it's procurement of the design team. And the big one, which we're talking about a lot today, is after a year of deliberation by a procurement subgroup, that we settled on the two-stage tendering process as being the most appropriate for the job. And that wasn't because we sat around and we said, this is it. It's because it's acknowledged and accepted internationally as the best practice for delivering large, complex projects. And there are...
Sorry, by whom? By the building sector, is it?
No, by very... I mean, even if, like, within the report, so it's not... It's actually... It's by clients and governments, and it's used even at the... Like, it's been used in Ulster Hospital. It's used widely in...
So it's used in what hospital?
Ulster Hospital.
Correct.
Sorry, which hospital, sorry?
Ulster.
And did it go over by 100%?
So it's been used in the NHS in the UK has a UK Procure 22.
And so in the UK or in the other examples that a two-stage process, did it go over by this percent? Simple answer.
Yeah, I'll give a
I'm under pressure for time.
It's okay. Well, I'll give a simple
6 minutes.
answer. Yeah, no, I'll give a simple answer. It's now. We'll measure that between now and 4 years' time, because the contractors in the two stages it's at the end. It's at the when you have your design finished, and now as we have cost and program certainty, and the test of the two-stage system is between now and the end of the day. On the basis of the work that's been done with the design team and the contractors working together to get down this to the finest.
The day has ended in Ulster Hospital and in those other hospitals. So did they go over by twice?
Well,
is my question.
There's a whole...
I understand.
No.
I understand. We're only partially through the process.
Yeah.
In the examples you have used of Ulster and the NHS that are finished, did the two-stage result in such an overrun? Yes or no?
I don't have the information, John. I don't know if you have.
We'll have to look for that information for you, Deputy.
Yeah.
So, and just now, just as a lay person coming in here, you're sitting here as the people that were appointed due to your skills and competency, your words, to the board. And you're then telling me that a two-stage process is the way forward because it's acknowledged and accepted internationally as to be the best way. And then you reference Ulster Hospital and the NHS as organisations that have used this model. And then you can't answer me, did they have the same problems? It seems like a very simple piece of information that people such as yourselves with the skills and competency should actually have that sum. I don't think it's an unreasonable question to ask this morning.
That's fair enough, Deputy. But as I said, we spent a year looking at what was the most appropriate procurement method here for the contractors. And within the report, I quote information generally from the UK, because obviously there's an awful lot more of large-scale complex projects being delivered in the UK than there are here. But I'll just read this. The construction of...
No, I don't want you to read it. We're under pressure for time.
It's important.
No, I know it's important, yeah. But I'm here as a questioner, you're here as a witness. And I have asked you a very simple question, I think. And I would like that answer to this committee as soon as possible. Because ye must have it. Or somebody must have it. And if you don't have it, we have a serious problem. If the model that you're purporting to be the best model and you haven't looked at the outcomes in terms of cost overrun in other countries, that's my point. Because at the start of the meeting today, you spoke about cables and not known, so you had a price for the cable. It just seems absolutely insane that you had a 5 kilometre, 5.5 kilometres of cable. But like in your first phase of pricing, you didn't know like how many rows and how many strips of cable, how was it going to be 5 by 5 kilometres? Like that just seems like, how could you start off a tendering process without knowing, you know, how much wire you needed? I mean, it just seems, or how you wouldn't have a sum built in for that, and you'd say this could go between X and X by 10 or whatever.
So just back again to just explain the process. First of all is we did deep analysis in terms of ultimately deciding that the two-stage process was appropriate for this project, right? And one thing that's for certain is that, this has been learned here in Ireland and the UK and internationally, is that the model of traditional tendering, where the client designs it without any involvement with the contractors, has proven over and over again that it fails because the contractors invariably, and it's a very competitive marketplace, the contractors invariably bid at cost or below cost and trying to exploit the opportunities if there's a looseness in the contract documentation. So the two-stage tender, it's done on the basis that you work on the basis of a preliminary design, that the contractors then work with the design team to develop that to a completeness, and then the contractor takes the risk from this day forward. And it's proven, like there's any amount of literature, and we're happy enough to share.
I have no problem understanding what
just
I
so
have.
that you understand,
Excuse me, Mr. Costello, I have no problem understanding what you're saying. But what I'm concerned about is that you're saying that the traditional model of tendering wasn't suitable in this. And I totally understand. If you have a theatre, you don't want to say this costs £1 million, and the builder to say, I'll do it for £1 million, and then shave off 200 by putting in a cheaper tile or wall or ceiling or whatever. I totally get this. So you don't have to explain it like this to me. My problem is the overrun and how you didn't see it. And it's so great, the overrun, and how you're purporting that this process is the best process, but yet you can't tell me how it worked out everywhere else. I think you can understand.
Thank you, Deputy O'Connell.
Yeah.
For making that
you're
point.
going to get me those. Can you just say for the record here that you're going to get me the overruns on the examples you have given today of how this is the best way to go about it?
In relation to the Ulster Hospital, we will find out for you what the outcome of that project was.
Thank you very much.
Yeah, because, finally, because if theirs was went over twice, well, you kind of should have seen this coming.
Senator Burke, thank you for your patience.
Just for clarification, I understand the Midland Hospital is 100% over budget from when it started. I know there were other issues there in relation to the builder, but my understanding is that it's 100% over budget. Just one or two issues there. First of all, in relation to the building of new hospitals in Ireland, when was the last major hospital project that was done in this country? And I'm talking major hospital project now. I'm talking about, where we're talking about a huge increase in number of beds or whatever. I'm just wondering, when was the last time there was a major project like this done?
The last one was the extension to the Mater Hospital. That's the most significant project done.
Single hospital would be Tala, is the one, and that is 20 years ago.
So that was
98, wasn't it? 98.
1998.
Yeah.
Okay.
And others have just been extensions to hospitals since then. Yeah.
Okay, so Tala was the last major project.
Correct, and Beaumont before that.
So you're really talking about going back 20 years for any kind of experience to be available. And I know you've experience in building, but we're really talking about a new area in a lot of ways, in that it's 20 years since the last major project was done. Yep. The second thing I just wanted to ask, the number of staff that will finally be working in this new facility, like are you adding up all of these, will all the staff transfer over to the other units? And what's the total number of staff that will be working in this new unit?
So, yes, you're right. So we're all one now as it is, which is very important. And so we currently have 3,330 staff within the Children's Health Ireland in the 3 locations of Crumlin, Temple Street and Tala. We are glad to report we actually have been funded for the staffing for opening up of Connolly, which is very helpful, and further service developments this year, which is a badly needed investment in paediatrics. Our projections are for 3,663 whole-time equivalents across the hospital and the 2 paediatric outpatient and urgent care centres. And we have developed a workforce plan to incrementally increase the workforce over the next years, as opposed to waiting until the last year. And I can report that we have been, while we acknowledge staffing is one of the challenges in new developments, the model of care that we're trying to implement, we have been successful in attracting people back to the positions. So we've had advertised 14 consultant posts, and they've been filled. I mean, in general paediatrics, I'm pleased to say 18 people applied, 12 were shortlisted, 4 were appointed, and we had put 2 on a panel, which is fantastic. So we know that there is a desire to return to the Irish health system, but it has to be done in a way whereby there is investment in what's been done, and we're transforming, we're making a difference to how we want to deliver health system, and that seems to be able to attract people. We have also been successful in planning the nursing recruitment for the paediatric outpatient urgent care centre at Donnelly, and more importantly the backfilling within the existing hospitals is well advanced as well. Glad to report.
Does that include catering staff and maintenance staff, or is it just
yes,
purely medical staff?
Our total number for workforce is everybody.
Okay.
Yeah, thank you.
Senator, thank you very much. So thank you very much for your time. We've been here over 4 hours now, so thank you very much for your perseverance. So Mr. Pollock, Mr. Costello, Ms. Curtis and Ms. Hardiman, thank you very much for coming in. This meeting is now adjourned until next Wednesday at 9 a.m. when we'll hear from the Department of Health and the Department of Public Expenditure and Reform. Thank you very much. Is that agreed? Agreed.